इधर से डाल दो ना. She's here, washroom गई.
मैं डिस्प्ले दे रहा हूँ. सर ये लीजिए.
Several studies have shown that an infection is caused by the presence of milligrams of tissue in the body. Surgical sutures can get contaminated by bacteria present in the environment or through the patient's own normal flora. It is now widely accepted that the suture material provides a nidus for microbial adherence and can lead to wound contamination. Surgical site infection, SSI, occurs when pathogens proliferate in surgical wounds, resulting in an impedance to wound healing. When suture is implanted, a coating of protein is formed around the suture, which becomes a site for bacterial colonization. This further leads to a biofilm formation on the suture surface, allowing the bacteria to resist the phagocytic activity of the leukocytes. This condition thereby leads to a prolonged infective state because the formed biofilm is capable of resisting the activity of systemic or topical antibiotics. This biofilm formation can even lead to an aggravated state of antibiotic recalcitrance, where the bacteria present inside the biofilm attain the capacity to survive even under higher antibiotic concentration due to formation of an isolated state. Today, SSI is highly prevalent among surgical patients around the world. It is rated as the most frequent complication in this patient population, being responsible for 38% of infections, and majority of the SSI are caused by Staphylococcus species of bacteria. Thus, SSI has become one of the major concerns among hospitalized patients. As per evidence, SSI is associated with high clinical and economic burden, increasing hospital stay of patients by up to 3 to 20 days. SSI is also associated with a mortality rate of 3%, and 75% of the SSI-associated deaths are directly attributable to the S. There is a significant relationship between SSI and diabetic patients. Hyperglycemia is controlled for surgery or during hospital stay, but majority of the patients fail to manage it after discharge. Keeping in mind all the problems which are responsible for surgical site infection, a new approach was developed to reduce complications of SSI. This approach should help us to prevent these major problems. Antibacterial sutures have proven to overcome the serious problem of SSI by preventing bacterial colonization, which will further not allow biofilm formation and antibacterial recalcitrance. We affirmed this by conducting a test at our laboratory with Mitsu AB antibacterial suture and plain suture. Petri plates were inoculated with bacteria, Staphylococcus aureus or E. coli. In the suture was surrounded by bacterial colonization, whereas a shield is formed around Mitsu AB suture, which protects the suture from bacterial colonization. In this zone of inhibition, bacteria did not grow around the suture, which is coated with antimicrobial agent triclosan. This shows that triclosan in Mitsu AB inhibits and does not allow bacterial growth and bacterial colonization on sutures. It offers a safety shield. Mitsu AB is a braided absorbable suture made up of biodegradable polymer, that is, polyglactin 910, and is coated with powerful antimicrobial agent triclosan. Mitsu AB provides reducing bacterial colonization, biofilm formation, reducing antibiotic usage, reducing chances of hospital readmission, reducing the length of hospital stay, and hence the economic burden, reducing complication in diabetic and immune-compromised patients. Mitsu AB provides a safety shield and helps to reduce the problems associated with SSI. Several studies have shown that an infection is caused by the presence of millions of bacteria per gram of tissue in the body. Surgical sutures can get contaminated by bacteria present in the environment or through the patient's own normal flora. It is now widely accepted that a suture material provides a nidus for microbial adherence and can lead to wound contamination. Surgical site infection, SSI, occurs when pathogens proliferate in surgical wounds, resulting in an impedance to wound healing. When suture is implanted, a coating of protein is formed around the suture, which becomes a site for bacterial colonization. This further leads to a biofilm formation on the suture surface, allowing the bacteria to resist cytic activity of the leukocytes. This condition thereby leads to a prolonged infective state because the formed biofilm is capable of resisting the activity of systemic or topical antibiotics. This biofilm formation can even lead to an aggravated state of antibiotic recalcitrance, where the bacteria present inside the biofilm attain the capacity to survive even under higher antibiotic concentration due to formation of an isolated state.
But don't worry.
Today, SSI is highly prevalent among surgical patients around the world. It is rated as the most frequent complication in this patient population,
Good morning,
being
everybody.
responsible for 38% of infections, and majority of the SSI are caused by Staphylococcus species of bacteria. Thus,
I've operated
SSI
sessions
has
in
become
Takshashila
one of the
Hall
major concerns
and
among
ART
hospitalized
academic
patients.
sessions in this hall.
As per evidence,
It's a
SSI
Sunday
is
morning, I can
associated with
understand how it is
high
on a
clinical
Sunday,
and
but
economic
still we have
burden,
all of you
increasing
and we are
hospital
lucky to
stay
have
of
you.
patients by
So
up to
without
3 to
wasting
20
time so
days.
that we don't fall
SSI is
short
also
of time.
associated with a
And
mortality
maybe
rate of
yesterday's two
3%,
sessions which we
and
missed out on, the two
75%
panels,
of
that
the
is
SSI
endometriosis
associated deaths
and
are
complications.
directly
If you can
attributable
just-
to the
we'll just,
SSI.
fit
There
them
is a
in today's
significant
session. I'll try
relationship
my
between
best to fit
SSI
them.
and diabetic
Dr. Aradhana
patients.
also has a lecture.
Hyperglycemia is controlled for
So we
surgery
can take
or
a lecture
during
today.
hospital stay, but majority of the patients fail to manage it after discharge.
So we'll
Keeping in
start
mind
today's
all the
session.
problems
So
which
our
are
first
responsible
session
for
for
surgical
today
site
is
infection,
master
a
videos,
new approach
how
was
I do
developed
it.
to reduce
So we have,
complications of
different
SSI.
eminent
This
doctors
approach
from
should
different
help
parts
us
of
to
the
prevent
country
these major
presenting
problems.
their videos
Antibacterial
and,
sutures
how
have
they
proven
do
to
it in their
overcome the
style, in
serious
their
problem
fashion.
of SSI
So
by
we'll
preventing
start the
bacterial
program for
colonization,
today.
which
And
will
our
further
opening
not
participant
allow
for today
biofilm
is
formation
Dr. Archana
and
Dwivedi, ma'am.
antibacterial
Dr. Archana
recalcitrance.
Dwivedi.
We
And
affirmed
I
this
welcome
by
our
conducting a test
chairpersons.
at our laboratory with Mitsu AB antibacterial
Dr. Kishore
suture
Nadkarni,
and
sir,
plain
can
suture.
you please chair the
Petri
session?
plates were inoculated with bacteria, Staphylococcus
And
aureus
Dr. Aradhana
or E.
Dabar.
coli. In the
And
result,
Dr. Navneeta,
plain suture
please
was
chair the
surrounded
session.
by bacterial colonization, whereas a shield was formed around Mitsu AB suture, which protects the suture from bacterial colonization. In this zone of inhibition, bacteria did not grow around the suture, which is coated with antimicrobial agent triclosan. This shows that triclosan in Mitsu AB inhibits and does not allow bacterial growth and bacterial colonization on
Dr.
sutures.
Meeta
It
from
offers
Gulbarga,
a
please
safety shield.
chair the session.
Mitsu AB is a braided absorbable suture made up of biodegradable polymer, that is, polyglactin 910, and is coated with powerful antimicrobial agent triclosan. Mitsu AB provides reducing bacterial colonization, biofilm formation, reducing antibiotic usage, reducing chances of hospital readmission, reducing the length of hospital stay, and hence the economic burden, reducing complication in diabetic and immune-compromised patients. Mitsu AB provides a safety shield and helps to reduce the problems associated with SSI.
Welcome, Dr. Archana, ma'am. I can't see.
No, it's okay. I think I'm here with Kishore sir chairing the
And
session is an honor to me
and
itself.
Everybody knows you, though we haven't said hello, we know you very well.
Thank you
Welcome,
so much.
ma'am.
Thank you. Thank you, chairpersons. And let me special mention that having Kishore sir in the audience as a chairperson gives my presentation a little extra boost. You'll come to know why I say that. We all know that doctors have become really endangered species nowadays with medico-legal litigations, and also we have to be on our toes whenever we plan a surgery, maybe any modality you're using. So this is what I wanted to highlight, that we are endangered species and we should be very well aware of what we should be updated with. So I am presenting a case of a woman who was 39 years. She presented in emergency with acute abdominal pain, vomiting, restlessness, diarrhea. She had not passed any urine since 3 p.m. on 28th of March 2013 and a definitive history of having hysterectomy 1.5 years back. When she was examined, she was conscious, temperature was normal, tachycardia was there, hypotension was there. She had pallor, oliguria as I mentioned, and there was abdominal distension with tenderness in the suprapubic region. So the patient was resuscitated by the physician as we have a CCO facility in us, and then we decided to take it up for further management. Her investigations, as you can see, her hemoglobin had a drop and other things completely fitting into a so-called normal picture. Only finding when the bedside USG was that there was a 500 ml fluid with no other finding to go with, and tapping was done and came out to be a hemoperitoneum. So the provisional diagnosis of acute abdominal pain with shock, impending acute kidney injury, secondary to some organ pathology, and the surgeon was called in and the patient was decided to taken up for diagnostic laparoscopy. So what did I do in the picture? I came in the picture because patient had complete faith in me. She said, if it's a laparoscopy, let madam stand by my side. I will not go inside without it. So this is what I saw when we entered the abdomen. You can see a huge amount. Can we have the slides off so it will be more visual? This is a case where there was a massive hemoperitoneum, and with the suction, as we went little lower down, you can see this is the fallopian tube and this is the ectopic ruptured pregnancy. So this was out of the blue moon, which we didn't think about. And the surprise doesn't end over here. Yesterday we were discussing NDVH and its possibilities in the hall with Soumya there and Kishore sir to boost up my morale. And this is why I was very keen that we should always resuture the vault. As you will see, this is the other side of the fallopian tube. As it is removed, very gently. So there is a dictum nowadays that we are removing the tubes. I think that is for the good of the patient. And as I proceed into surgery, you will see this is what was the culprit. Can you see a small fistula, the rent in the vault of the vagina? So we were still very not sure, so we decided to put into the methylene blue dye whether it is a bladder, because we also did not think that it has to be coming from the vagina itself. So when we push the methylene blue dye, you will see it passing very clearly very soon, and this is it. So a clear rent in the vault of the vagina where the tube prolapsed. So whenever we are doing the vaginal hysterectomies, there are more chances the tubes get prolapsed and they fix it there. And this is what was the end result. And patient was saved and she was very happy, and she was not ready to believe that she had a ruptured ectopic, that is almost 1.5 years post-hysterectomy. So this was a nightmare, and as I would like to say that after finishing the surgery, we went for the retrospective analysis. Her UPT this was a retrospective finding where the beta HCG was more, and although the operative narrative held them available to the physician treating the ectopic pregnancy after hysterectomy, but the vaginal cuff infection is one of the very common cause, or hematoma formation after hysterectomy, which can lead to the formation of granulation tissue, and a prolapsed fallopian tube is the culprit which can cause such picture. So adnexal structure tend to be brought into the closer proximity. So ovary is near the vaginal cuff and the fallopian tube, which has to catch the sperm and the egg. It is more type of a vagina to peritoneal tubovaginal fistula, I would say. So when the chances increase post-vaginal hysterectomies, and also when we do a subtotal hysterectomy where we leave the cervical stump, and however you cauterize it, there is a small amount of rent or the canal is dilated. This may need increase the possibility of formation of the fistulous tract. So 56 cases of ectopic pregnancy was reported in 2010 by Alzheimer's reporting, and 31 was the early presentation and 25 was late presentation. Early is within 2 years, and after say 25 cases, the pregnancy was reported, certainly developing a result of communication between the vagina and the peritoneal cavity. So it is a very uncommon event, but not a rare possibility nowadays because its frequency is increasing. We have more hysterectomized patients at a very younger age, where people tend to sometimes spare the tube and ovary both. So since first reported by Wendler in 1895, 6 cases post-hysterectomy ectopic was detected, and the author reported it in 2009. Since that publication, 11 subsequent cases have been reported, and total published cases now are 71. So maybe it is not so rare, but it is a possibility that exists, so we all need to be ectopic minded. So what I want to have a take-home message that whenever you are doing a hysterectomy, please remove the fallopian tubes, because not only the cancer is prevented, but post-hysterectomy ectopics can also be prevented by this. And remember, there is early presentation and late presentation. So whenever the patient comes to us, please be ectopic minded, because it has been hypothesized that the fallopian tube prolapse after vaginal hysterectomy increases the risk of ectopic pregnancy, and removal of fallopian tube can help us in such emergencies. Now, I'll leave it to the audience. Can you identify what I'm trying to show in this video? Anybody? We have to be very quick. It looks like a rudimentary horn, right? No, it is a chronic ectopic. And, yeah? Corneal ectopic. And this patient was admitted again with the physician, and the physician said that this is a diarrhea and all those symptoms irrelevant. Since I had operated that case, probably I had become ectopic minded, and so we could relieve this patient also. So a quick rapid fire for the audience again, that up to -% of ectopics go undetected on initial presentation to the emergency department. Anybody can take the guess. So it is more than 50%. Actually, 55% is, I'm not talking about post-hysterectomy. It is almost because patient comes late or patient comes early, so we have a misdiagnosis all the time. This is a busy slide, but the crux of this is that remove the fallopian tube, and there is a high incidence of ectopic pregnancy, and we should strongly consider the implementation of universal progesterone screening program to decrease unnecessary patient morbidity and risk of mortality from undiagnosed ectopic pregnancy. So this is the last slide. Thank you for the patient watching. So this is a technique how to lift the wrong weights, wrong way to lift the weights. So this is a child who's struggling. So that was the wrong way. Now the right way you can see. Yay. So this is what we can do, we should do. What we cannot do, we should not put our energy and stamina into that. So we are gynecologists, we should be ectopic minded, and we should remove the fallopian tubes in the want of good outcome for the pregnant patient. Thank you so much for the patient hearing. Yeah. Sorry, sir? Yeah, that is the CT scan. There was no time. Patient was already into a hemorrhagic shock. She was revived. She came in emergency. There was we had a needle aspiration, hematoperitoneum, USD was done. So she had to be explored. But nobody was thinking about the gynec etiology. That is what I wanted to highlight in this case. So thank you so much, ma'am.
Thank you, ma'am. That was a small presentation, very crisp. And I think everybody did not, everybody was too attentive seeing your videos and hearing the presentation. Like you said, ectopic minded, I would share a short case. Rather that's the index case, the only reported case in literature. We had a patient from Lucknow, okay, she got an IVF done in Lucknow, came to us for the first initial few months ANC, referred by our gynac friend. When I did an ultrasound, I found an intrauterine pregnancy. I've published a series on heterotopic pregnancies with the at 21st century. And there was an intrauterine pregnancy, and also there was a pregnancy. It appeared in the myometrium in the posterior wall. Till then, I had not seen a myometrial pregnancy. Great. I was not sure, but it appeared that it's not in the uterine cavity. So I sent her to a very leading radiologist, and the report that we got was a left tubal ectopic and an intrauterine. Fine. Then the patient came to us 3 days later, and at that time I was somewhere in an emergency with my family thing, and she came there. Just in the pre-op she had tachycardia. When we took her in the OT, there was 3 liters of hemoperitoneum, and when I sucked out the blood, I found that the tube was intact with the ectopic in situ. I kind of got a vasovagal. If the tube is intact with the ectopic,
where is it?
When I know, what did I hit? And then I lifted the uterus. She had a myomectomy 3 months earlier.
Okay.
And there was a myomectomy site pregnancy which had ruptured. And she was pouring blood from there. I immediately gently sutured that area, removed the tube intact with the ectopic, sent both for histopathology. They both came positive, and the intrauterine continued, and she delivered at 33.
Great. Wow. We should have an applaud for that.
So that's how ectopics can behave, and that's how our stream is. So.
Yeah. So I should thank Aditi for giving me this chance so I could interact with one more good case right now.
Yes,
Thank you so much.
Thank
you,
you, ma'am.
Chairperson.
Very interesting case, Dr. Aradhana. And very nice presentation, Dr. Archana ma'am. So now we go on to the next speaker, Dr. Nancy Chakrabarti. Dr. Nancy, she's from Hisar, Haryana. I welcome you, Nancy. Nancy and me, we were classmates in MBBS, and we know each other since then. And we used to both compete in singing competitions, and she used to always get the first prize.
No. Thank you so much. Thank you, Kishore sir. Thank you, all the chairpersons. Thank you, Aditi. Thank you so much. I bring greetings from Maharaja Agrasen Medical College, Agroha, Hisar, Haryana. I, Dr. Nancy Chakravarti, working as Associate Professor at Agroha, will discuss my journey till now, that is segue from classical to laparoscopic surgeries. Why laparoscopic surgeries? because there is less post-operative scarring, reduced pain, shorter recovery time, lesser time of the patient being spent in the hospital, reduced hemorrhage, quicker return to normal activities, and reduced wound infections. We started our journey way back in 2018. As we all were new and untrained, so we faced a lot of difficulties. In January 2019, I came to attend Nadkarni's Training Institute and Academy. Earlier, we were using 1 primary with 3 secondary ports, which got reduced to 2 secondary ports after returning. From 48 cases in 2019, we came to 76 surgeries in 2022. Initially, as we all were untrained, so there was a lot of time which was spent during the surgeries, which was cumbersome. In January 2019, I attended the 15-day fellowship program at the Academy under the expert guidance and mentorship of Dr. Akshay Nadkarni. This helped me greatly as it improved my skills day by day, helped me coordinate better with my colleagues, improved the quality outcome of each selected cases, and it reduced the duration of each surgery over the next months. What I learned over the months and the years was, earlier, since we were making multiple ports, that was cumbersome. It required an extra assistant. There was clashing of the instruments with each other, which created a lot of annoyance. After training under Dr. Akshay, this changed drastically as we started making 2 ports instead of 3 ports. I improved and also trained my colleagues as well as juniors with his teachings. This is how we progressed from 48 to around 80 cases in 2022. The problems that we faced during our journey were selection in the cases as to which case has to be taken earlier by a beginner, the patient positioning, which got better, port placement and ergonomics, hand-eye coordination, anesthetic problems, operating surgeon, and coordination with the assistant. Initially, as a beginner, I would say that we should go in for the simpler cases, for the simpler uteruses, which are small. Patient positioning came to modified Lloyd-Davis position and placement of a bolster. The port placement got better, and there was better ergonomics which developed. There was better hand-eye coordination. Anesthetic complications improved, and difficulties in orientation with the laparoscopy instruments improved over the months. These were the difficulties in the ergonomics. These were like the suturing techniques, the prior inspection, placement of carts and monitors, and specifications of instruments. Over the years, we have been doing simple TLH in simple uteruses, previous LSCS, previous 2 LSCS, big fibroids, ovarian cystectomies, including simple cysts, dermoids, ovarian cystadenomas, and ectopics, lap myomectomies, lap pectopexies, lap sterilization, lap recanalization, diagnostic lap hysteroscopy, along with hysteroscopic removal of copper T adhesions and small polyps with tubal cannulation. I will be sharing a small video on TLH with you. This is a case, para 3 L3 with 42 years of age, who came to us with heavy menstrual bleeding since 1 year, with pain in lower abdomen and constipation since 6 months. On per abdominal examination, it was 14-week size uterus. On ultrasound, it was 7 into 7 centimeter posterior wall fibroid. So beginning with the first step, we are taking a harmonic and a bipolar shearer. And in this particular case, we have one more assistant standing on the right-hand side of the patient. We are beginning with the coagulation of the round and the tubo-ovarian ligaments using ligashore, using a harmonic and bipolar, starting from the round and the tubo-ovarian ligament. That is a coagulation being shown, and finally the cutting, which is being shown on the right side of the patient using harmonic. After this step, we begin with the opening of the anterior leaf of the broad ligament using the bipolar and the harmonic, and the countertraction being given by the assistant standing on the right-hand side. We proceed from the right side of the patient towards the left. After completing the anterior peritonization, we go on to opening the posterior leaf of the broad ligament, starting from right side, going towards the left, using the harmonic. This is the skeletonization of the uterine artery being shown on the left-hand side. After this step, we further push down the bladder fibers, like it's shown, in order to get a good plane for colpotomy. This is being shown from the left-hand side towards the right-hand side. Similarly, we go posteriorly. As we go on to the posterior dissection, we go up till the tip of the uterosacral ligaments using harmonic. Then we are doing the uterine artery coagulation using bipolar, with lateralization being done with harmonic. That is the lateralization of the stump. Now we have a good plane. We begin with the colpotomy anteriorly using a monopolar hook. There it goes laterally, posteriorly, and then laterally to anterior, where it's over. The uterus is being delivered out vaginally. We do the endosuturing using vicryl number 1 in a continuous manner. Here, the traction is being given by the assistant standing on the right-hand side. As we complete the suturing part, we check out for the hemostasis. The peristalsis of the ureter is being checked. Lastly, it is the irrigation and the suction which is being done. That's all. Thank you so much.
That was a wonderful presentation, ma'am. So nice to see your journey from beginning till doing TLH independently.
Thank you so much,
That was
ma'am.
inspiring.
Thank you so much, ma'am.
Very
Thank you.
minimal blood loss. There was, in fact, nothing.
Thank you. Thank you so much, ma'am.
Ma'am.
Thank you, sir.
Ma'am, you said you shifted to 3 ports initially.
Yeah,
When
just
you
because
said
in
you
this-
could see 4 ports. So when do you decide to go for 4 ports?
4 ports, it depends upon the patient profile, right? If it is a bigger fibroid, like in this particular case. For the smaller uteruses, we are generally using the 2 ports technique, but it depends upon the case. As in when you need the manipulation, when you need traction, we put the manipulator, it is the assistant also who is giving the traction, and from the vaginal end also, one person is manipulating.
So ipsilateral port position on the left side and 1 traction on the right side.
Yeah. Thank you.
Like you said, you started you started your journey here and you mentored under Dr. Akshay. The best part is that he's one of those busiest people with academics, conferences, lot of surgical work, family, but still he's one of those few teachers who goes to the students' places so that they can begin their,
Yes, ma'am.
laparoscopy teaching that they've learnt it here. That's something which you cannot find easily.
Yes, ma'am. Correct, ma'am. Thank you. Thank you so much.
Thank you, Dr. Nancy.
Thank you.
We welcome Dr. Vipul Kapadia, sir. Welcome, sir.
Next, we welcome Dr. Prabhakar Singh from Surat. We all know him, so he'll be talking upon the topic, setting up a PGT program in your center, good practice guidelines. Dr. Prabhakar is a very well-known name. He's the man behind the
more patients coming forward and asking for it as a strategy. There has been a lot of evidence on how PGT can improve outcomes in specific group of patients, especially, not all. There's enough data. Our culture systems have improved, so now we are doing mostly blastocyst transfers, which was like done by very few centers. Now almost every center, small, big, large, whatever, is doing a lot of blastocyst transfers. There's a lot of consistency in our IVF labs. There is no variations. So that gives us a good platform to, kind of think and do PGT, because the primary requirement for PGT is, you have to do a blastocyst culture. So we'll just look at what a lab needs, what a clinician needs, and what kind of things that you can start preparing. You may not do immediately, but at least you have to start preparing your lab for that. So prerequisites, lab setup, obviously, that there are some specific requirements that we need in the lab. Equipment, validation of the lab, support procedures in the lab, training of the team, counseling of patients. So there's a different type of counseling that goes into when you're recruiting a patient for PGT, which might involve a separate genetic counseling as well as a clinical counseling about the results, how they are not very accurate, how accurate they are, what are the problems with the results, what can happen, you may get result, you may not get. So there's like lot of, you will need to add a little bit to your existing IVF counseling and do that, and take time to do that, because that is very important. Document control is very important, because in IVF, we are looking at, you're tracking only patients, but when you're coming to PGT, you are tracking embryos. So it becomes a little bit more difficult, more tedious, and you need to be a little bit more careful when you're doing that. Audit is important, because whatever you have done, how you have done, what are the missed abortions, the problems with biopsy are there. It is not a very safe procedure in unsafe hands. It's a safe procedure only when you have a team which knows what it is doing. And is it indicated? So that's a few things that we'll touch upon. Lab setup. So aim to ensure optimal conditions for extended culture. So the first thing that any IVF center wants to do is you follow the trend, right? You come to Pardi, you come to Vapi, you come to Surat, you go to Bombay, you train yourself under one of the best IVF centers, and then you want to go back and then you want to follow those practices, right? But it doesn't work that way as far as a lab is concerned, right? You come to Surat, you see we are doing PGT, so many cases of PGT. We are doing only blastocyst transfer. You go to Bombay, you go to Delhi, you go to good centers, all of them have moved to blastocyst transfers. But that may not be the way you start your lab, right? You cannot just start your lab and decide ki from day one I want to do blastocyst transfers, from day one I want to do biopsies. It doesn't work that way. There is a learning curve, there is a time. It takes a little bit of time for the lab also to get used to it, the staff to get used to it. So what you see you may not be able to replicate the same thing in your lab or in a new lab for a center. For example, we started our Baroda center 1 year back, we didn't start doing blastocyst transfer from day one, because even if we have the same team which is doing cases in Baroda, the lab is new. We are still not sure about the culture conditions. So you don't want to risk all that by doing. So what I'm trying to say is, what the best are doing, you want to aim for that, but to reach that is going to take you a little bit of time, and time is something you cannot just avoid. It is a lot of patience and a lot of hard work. It will come gradually, but you can't get too fast. You need to culture till blastocyst stage. We can do day 3 biopsies, but it's not the optimum stage. Air quality, low oxygen cultures, that means you're using a triple gas culture that gives you better blastocyst development rates. Frequent calibrations and micromanipulation with laser. So laser is an expense that you will need to invest in if you are starting a PGT program. You can always hire a laser. There are people who, kind of rent out a laser. So you might want to start with that. If your lab is going to cost you 50 lakhs today as a new lab, a laser costs 30 lakhs. The laser itself costs 30 lakhs. So it's an investment that you need to figure out whether it will justify your returns also, because eventually you need to run your center also. So technical expertise, oocyte, good quality and quantity. So your stimulation protocols have to be very standardized. Optimizing the sperm selection criteria. So you should have your andrology set up. What is the secret recipe for blastocyst culture? We still don't know, but you need to have that secret recipe. You should have a lot of cases where you were able to culture and get your blastocyst rate up to the benchmark levels. Laser assisted, so laser is needed. So you should be good at doing laser assisted hatching. And blastocyst vitrification and warming. Now, if your blastocyst vitrification is suboptimal, you should not be doing PGT, because the primary requirement or prerequisite is that your blastocyst vitrification and thawing has to be as good as a fresh blastocyst. You cannot have कि blastocyst नहीं मिल रहा है, thaw किया तो खो गया है, thaw किया तो brown हो गया है, collapse हो गया है, damage हो गया है. If that is what is happening in your lab, you're not ready for doing embryo biopsies. I said counseling, document control, training of the team, and audit is important. Now PGT-A. So previously we used to call it PGS, pre-implantation genetic screening. But in the last 3 years, the terminology has changed, and now we call it pre-implantation genetic testing, which is divided into basically 3 parts. PGT-A is an aneuploidy screening. Aneuploidy screening is just screening all the embryos for aneuploidies. You're not looking at specific disorders in that. So PGT-A, as per the guidelines, is recommended in recurrent implantation failures, idiopathic recurrent pregnancy loss, where you are not able to find out why is it happening. Advanced maternal paternal age, highly recommended. Now, the cutoff for advanced maternal age is little dicey. Like American Society says 37, 38 years. In India, we follow 35 years. So, thoda sa fluid hai, but still you have to have a cutoff. Severe male factor infertility has shown that PGT might benefit from that. And to pick an euploid embryo for optimal outcome, and that can be like you're trying to select the gold standard embryo, and future, you might be doing PGT in all cases just to select the euploid embryo, right? So, that can be a thing, but it is actually not an indication right now in terms of that. The PGT-M is for monogenic disorders. Monogenic disorders is thalassemia, sickle cell, motor neuron disease, where you're trying to figure out a particular disease which is transmissible from the parents, and you're trying to prevent that particular disease in the progeny or the offspring. So here you're not looking at aneuploidy, you're not doing PGT for IVF or infertility, you're doing PGT for a patient who wants a healthy, normal child without that particular genetic disease. That doesn't mean if you're looking for thalassemia, you might end up having a random mutation with something else. That is possible. You're not screening for that, but you're just screening for that particular disease. Most commonly, we get a lot of patients of thalassemia. It's kind of endemic in this area, sickle cell. And we get very rare disorders like mental retardation. You get like autistic things where you are doing this. We recently had a patient who had a child who had a particular kind of a genetic mental disorder. and it was autosomal dominant from the father. So it is not infertility. So what do you expect? The patient is like what, 33-year-old female? She gave 23 embryos, 23 blastocysts. Obviously, the patient is, she's normal, PCOS. 23 blastocysts, we did PGT, we got only one normal. Only one embryo out of those 23 did not have that particular genetic disorder. We transfer that and she conceived. So conception is not a problem. Only thing is we need to select that particular embryo which does not have that genetic defect. So it happens. Recently we had a patient of 42-year-old female, very poor ovarian reserve. We got 6 blastocysts, all of them abnormal. So we couldn't transfer anything. This patient had 3 IVF failures without PGT testing. Now she was frustrated and we offered her PGT. Now we cannot transfer, obviously. Now we know why she failed. So that also solves a lot of dilemmas, a lot of patients question why it failed. You have a reason why this particular failed. So PGT-M, single gene disorders like thalassemia, as we have already talked about. And this is a flowchart of how a PGT cycle actually flows. These recommendations, these are not my recommendations. Ashray has a very good document on good practice guidelines for PGT. The Indian Society of Assisted Reproduction also came out with a document on good practice guidelines for setting a PGT program, both freely available, just download it from the website. This picture is just from there. So just shows how the workflow or how the patient goes through all these steps in this. So you have all the 3 PGTA, PGT-SR, PGT-M, counseling, biopsy and tubing. So you do the biopsy, you tube, you send it for testing. Testing is basically amplification with NGS. If you're doing PGT-M, then mostly it is Sanger sequencing with PCR. And then you get the results, you transfer, and that's how the flow goes. This is a simple process of different types of stages where you can biopsy. You can biopsy at 2PN stage, you can biopsy, polar body biopsy can be done at oocyte stage also. You can do a day 3 biopsy, but most preferable, 90% of centers across the world do a blastocyst biopsy. Now these are the options, thoda sa theoretical. So the whole idea is that you need to puncture the zona to get the tissue out, right? It's very simple. How you do that? Previously, people used to do a mechanical zona dissection where they used to use the pipette. They used to hold the pipette and the holding pipette and the ICSI pipette, and then you rub. So what happens? It creates a hole in the zona, and then you take out the blastomere. So traumatic problem is very difficult to learn. Secondly, there is a variation when you learn because it's very difficult to transfer that skill to the next person. Third, then you can use chemical zona drilling where you use acid thyroid solution. So you spray acid thyroid solution and that creates a hole in the zona. Again, acid thyroid is toxic. If you spray too much, it damages the embryo. Lot of variations in practice, so people stopped doing that. Then came the golden era of lasers, and people started using lasers for hatching, started to drill holes using the laser shot. It's very, very safe. It does not damage the blastomeres. There's a lot of data on that. The babies born are apparently, they don't have any particular abnormality or any particular defect which can be attributed to the laser. So it's a very, very safe procedure. So that is number one. It's easy to use, it doesn't take time, and there is very less operator dependence on how you use the laser. You just set the power and just shoot. So it's very simple. So which is the best stage of biopsy? As I've already said, you can do polar body, zygote, blastomere, trophectoderm, and blastocyst. But as I said, blastocyst biopsy is still one of the most favorite steps. This is an image of polar body. We don't do it. Very few people do it. You want to do polar body biopsy only when you want to rule out a maternal genetic defect, right? If only the mother has a genetic defect which is transmissible to the child, you don't want to biopsy the embryo, right? You can just do a screening of the oocytes and then you know which embryo has that maternal gene. You can ignore that. The only advantage of this is you're removing something that is not going to be a part of the fetus. So it's pretty safe, easy. It's a very early stage of the embryo development, so it does not harm. even if it causes a little damage, the embryo has the kind of the totipotency to get it sorted. So this is how you usually do. You take out the second polar body. So you can do that. You take out the second polar body and you can do blastomere biopsy later on. So polar body biopsy, less invasive, mirrors the genetic status of the mother. It's not of the embryo, the mother. Countries with strict regulation against, there are some countries which don't allow embryo biopsy, or they don't allow embryo selection at a blastocyst stage or a day 3 stage. Classical example is Italy. They don't allow that. So in that cases, if you want to do embryo selection, this is the way you can do it. Cons is it does not talk about the genetic status of the embryo. It is just the genetic status of the oocyte. Only maternal issues can be picked, and meiotic errors and post-fert aneuploidy errors will be missed and needs cleavage stage biopsy to confirm. So that is again, you have to do a second biopsy to do that. And of course, gender selection cannot be done. In some countries, people are doing embryo biopsy for gender selection. You cannot do that at polar biopsy stage. Cleavage stage, again, since you have like 8, 10, 12 blastomeres, you can pick 1 or maybe 2 in some cases, send it for genetic testing, and you get your results. Advantage, you get a lot of day 3 embryos. A patient who has retrieved 15 eggs will give you, say, 13, 14 embryos on day 3, but on day 5, that will become 5. So the number of embryos that you have, the pool to biopsy is bigger, but the problem is that since only 4 are going to be blastocysts, you have done biopsy in 10 patients which are not going to be blastocysts. So it's just extra money that you spent without any actual benefit out of it. So that is one thing that is a con for day 3. But if you have very less embryos, like 3, 4, and you are scared that blastocyst banega, nahi banega, you might want to do this. But still, with optimal culture conditions, this should not be a problem. So this is how they do. I'll not. Okay, देख लेते हैं. अच्छा video है. So you shoot the hole in the zona. So the problem with blastomere biopsy is that because of the tight blastomeres, the embryo is collapsing, the cell junctions are very tight. You can see that it is very sticky. So you need to use calcium magnesium free medium. Some people use that. So once you use calcium magnesium free medium, the blastomeres, they tend to loosen out and then it becomes little easy. It's very simple. Just what? 2.5 minutes. And if you don't see the nucleus in that, you can do another one. So you can actually do another blastomere and still the viability is not a problem. Blastomere selection, so you have to select the blastomere that you're going to biopsy. You should be able to see a nucleus in that. Some blastomeres don't have nucleus in that, so that becomes a little tricky. So cleavage stage pros, this is the best commonly used stage previously. No need for freezing. So this is an advantage. You do the biopsy on day 3, you get the results on day 5, you can transfer a fresh cycle. Now, most across the world, people have moved to a frozen cycle. Personally, we have moved to frozen cycle in all our patients, so it doesn't matter to us. Less operator dependent and easily reproducible, as I said. Can biopsy more cells. So if one cell is lyes, you don't see the nucleus, you can immediately go and do a second biopsy, second blastomere. And biopsy time is little flexible. You don't have to worry about that. Con, exposure to calcium magnesium free medium, as I said, which can be a little toxic. Removal of blastomere can have a negative effect. You're taking out almost 10 to 15% of the embryo. Blastulation can be hampered. High incidence of mosaicism because one blastomere does not represent the whole embryo. And high incidence of amplification failure than trophectoderm biopsy. This is just the technical side. Trophectoderm biopsy is much safer because the trophectoderm, we all know it does not become a part of the fetus, it becomes a part of the placenta. So you don't have to worry about the fetal development or anything. Large number of cells. Normal blastocysts will have anywhere between 60 to 100 trophectoderm. So even if you're taking out 4 or 5 of them, it doesn't matter. So you're just, it's a lot safer to do that. Your inner cell mass, which is the critical part of the embryo, is way away. There is no damage. There is no risk of damage from the laser. So you focus on the blastocyst. This is a little technical. I'll just show the video. So you can do blastocyst biopsy at different stages. People do it at day 5, late day 5, hatching stage. People hatch on day 3 so that the trophectoderm comes out by day 5 and then you biopsy. People do laser shots on day 5, do immediately biopsy. So there are different strategies of doing that, little technical, more for the embryologist. But you can biopsy this also, you can do biopsy in this also. There is no problem with that. The problem comes when you have small blastocysts, because then your cavity is very small and then trophectoderm is not very well developed. Okay, so this is one of my biopsies. So this is a nice day 5 blastocyst. It's like properly expanded. In blastocyst, you can wait. अभी आपने देखा सुबह expand नहीं हुआ है, दोपहर को देखो expand होगा. Because a blastocyst has a tendency to collapse and expand. So you want to biopsy it when it is actually fully expanded rather than, and not hatched, but fully expanded. Since the zona is already thinned because of the expanding blastocyst, you don't need too many laser shots also. So once you do the laser shot, one shot on the zona, one shot between the cell junction of the trophoectoderm, the blastocyst will collapse. See, it starts collapsing. You want to remove the trophoectoderm before it completely collapses. So that is what you don't want. You don't want a completely collapsed blastocyst. You want a collapsing blastocyst. So this is what will happen. The trophoectoderm starts collapsing and then you start holding it. It's a little trickier than ICSI, obviously, but if you are good with your tools, if you know your pipettes, if you know your micromanipulator, you should be able to do that. There is a steeper learning curve in this, but हो जाता है. So now you see that trophoectoderm has started collapsing, right? So it separates from the zona, and that is where you starts holding it. So you aspirate a particular part of the trophoectoderm, and then you start shooting, maybe 2, 3, 4 shots, and the tissue is out. That's it. Then you observe the blastocyst for a few seconds, whether it turns brown, whether there is too much of damage that you have caused. This is a very straightforward. So this tissue is what you send for, basically, genetic testing. You tube it and then you send it. So that's very simple. Pros: high technical and biological robustness of the blastocyst, lesser incidence of mosaicism, higher live birth rates. We all know blastocysts have that. Ideal stage of, if you are doing elective single embryo transfer, then blastocyst is better. Day 5, there is self-selection of embryos and lesser number of biopsies you will need to do. Applicable for good prognosis, that is a con. Culture system should be robust. Rebiopsy is not possible immediately because your blastocyst has collapsed. So you can't rebiopsy. So what you have to do, you have to wait again for say another 2-3 hours, let the blastocyst collapse. So basically a biopsy goes on for the whole day or maybe even 2 days. Sometimes you end up doing the same patient biopsy across 2 days. आज एक blastocyst बना, expand हुआ, उसको biopsy किया. दोपहर को एक blastocyst बना, उसको biopsy किया. शाम को एक बना, उसको biopsy किया. Day 6 पे 2 बने, तो उसको biopsy किया. So it becomes very difficult to schedule a biopsy if you have a freelancer embryologist, because a freelancer will not wait for 2 days, 3 days for you to do this. वो तो जो है वो करके चला जाएगा. So this becomes little challenging, but the lab is engaged. The staff is always, on the edge कि कब biopsy होगी कुछ पता नहीं है. रात को 9 बजे भी हो रही है, सुबह 6 बजे भी हो रही है. So it keeps the lab, on their toes. Non-invasive methods of embryo screening are now available, which is called NIPGT, which is very similar to what NIPT is done. The problem with NIPGT is that it's still not as it does not replicate the genetic status of the embryo as much as NIPT does for this thing. The concordance is only around 80%. So 80% of the time it is right, but right now people are doing studies where they're doing NIPGT and doing the biopsy and then seeing how much of concordance. They are optimizing the technique. I think it'll still take some time to go there. It's the ideal platform is FISH, CGS, वो सब चला गया है. Now people do only NGS. So this is our experience, which was published in Journal of Human Reproductive Sciences, which is an Indian journal, where we try to compare PGT in the indications that I suggested, namely advanced maternal age, RPL, RIF, and compare it with patients who did not opt for PGT, right? They'll all, obviously there will be patients who will say, no, madam, PGT nahi karana hai. There are financial problems, they don't understand what it is. So there will obviously be a control group, ऐसे ही बन जाता है. And there are patients who underwent PGT. And we got very good enough data. This was not much, this was only 33. So this is like 2021 data. So now we have crossed more and we'll add to this. But it does show that in advanced maternal age, the pregnancy rates are really higher. The live birth rates are higher. The abortion rates are less, especially when you look at RPL. The abortion rates were very less when we did embryo screening and by PGT. And in recurrent implantation failure also, we were able to get higher pregnancy rates and implantation rates compared to patients who did not opt for PGT. So this is again a free article. You can just go through it. There's a lot of it's a good review. So take home message for successful implementation of the PGT program, it has to be state-of-the-art lab. Both lab and the lab team should be geared to handle extended embryo culture till the blastocyst stage. ICSI is the preferred ART method. You cannot do IVF insemination because of contamination of the sperms. Blastocyst stage seems to be the beneficial stage. FISH is obsolete. Nobody does FISH. Single genome techniques like CGH and NGS. Nobody does CGH also. People do NGS only. If you want to do elective single embryo transfer of a genetically normal embryo with PGT seems to offer the better reproductive outcome than double embryo transfer. The problem with transferring two embryos is poor perinatal outcomes. A lot of problems during pregnancy, a lot of problems in cesarean. All those problems are solved when you're doing a single embryo transfer. So if you're looking at a healthy, live child, single child, PGT gives you that option. We had a patient who was obsessed with having only one embryo to transfer. And then we said, ki if you want to transfer one embryo, then you better go for PGT, because then we are convinced that we are transferring a euploid embryo. Follow-up of pregnancy till live birth is essential aspect of quality management system, because you want to see whether you have done PGT properly or not. So that is a little bit about PGT. I'll be happy to answer any questions. Thank you so much. Yeah.
Thank you, Dr. Prabhakar. Any questions, please?
Yeah, she has a question. You can say, I can hear you. Yeah, it's on.
Yeah, so when a patient opts for PGT, you tend to check all the embryos, or only a few ones would represent the whole thing?
No. Each embryo is tested. Na? You want to see each embryo, whether it is euploid, aneuploid. So each embryo you get a report. Okay. Embryo 1, euploid. Embryo 2, aneuploid. Embryo 3, euploid. Embryo 4. So it has to be all the embryos.
And what is the incidence of having any kind of aneuploidy or any kind of an abnormality when a normal patient who hasn't got a history of genetic
so you're looking at aneuploidy. You're talking about aneuploidy, right?
Exactly. Yeah.
So in IVF, age is a big problem, right? Yeah. Younger the patient, lesser the aneuploidies in the embryos. As your age increases, you will see more and more aneuploidies. So world over, the data says almost 30% of your embryos which you culture in an IVF lab across all age groups are going to be aneuploid. Aditi.
Thank you.
Morning, Prabhakar. How much does mosaicism hinder the counseling?
Yeah. So mosaicism, so what do we mean by mosaicism, right? So what happens is when you're doing a biopsy, you usually biopsy 5 to 6 cells. Okay. And so when you do the testing, which is NGS, they actually take out the genetic material of each and every embryo, each and every trophectoderm cells, and then that is run through the machine and all. So what happens is you get a mixed result. You see aneuploidy also, and you see a euploid trophectoderm. That is mosaicism, where the sample is mosaic, where some of it is aneuploid, some of it is euploid. So they give you a percentage value, that there is 25% mosaicism, 50% mosaicism, 60%. As per the guidelines, the recent guidelines of PGDIS, less than 25% mosaicism is acceptable to transfer. So that is how you counsel the patient, that if you have less than 25% mosaicism, we can still transfer it as a euploid embryo. More than 25, you should not, it is not recommended to transfer. So this is, so the report specifically mentions recommended, non-recommended. So our job is very easy because वो lab में लिखा हुआ आता है and recommended no. The clinician doesn't have to decide which embryo to transfer. The report itself comes with recommended and non-recommended report.
So I usually transfer mosaic embryos because I feel that like PGT is not everything. So we beg to differ there. So if there's a mosaic embryo, I will transfer. I do it for patient reasons also. Sometimes the patient says, I want to test all my embryos. But if I have one mosaic embryos, all other abnormal, then I counsel her that let's go for embryo transfer. And I've got good results. Till now, whatever mosaics I've transferred, they've conceived them, they've got healthy kids. So I'm still not... And I still feel that somewhere at the lab level, at the genetic testing level, if they don't get a result, they will report a mosaic. Because yes, it's true. Because they don't want to write, we could not get enough material. Yes, so they report mosaics if they are not sure of the result. So sometimes I feel that we might lose normal embryos, normal blastocysts in the testing process.
I think the lab should be more forthright in reporting because you still have many more embryos to biopsy.
So what happens is sometimes patient के financial issues भी होते हैं, right? So very simple example. If you are going to biopsy 5 blastocysts, it will cost you 1.5 lakhs. Apart from the IVF cycle. So this is what we charge. 1.5 lakhs includes the lab charge, biopsy charge, testing charge, everything is included. Vitrification, because you have to vitrify. Each embryo is vitrified on a different straw and tagged. So cost add hota hai, embryologist ka cost add hota hai. So laser ka cost add hota hai, which is a very big expense cost in that. So 1.5 lakhs aapko sirf 5 blastocysts ka. Now patient has say 12 blastocysts. So that cost jumps to 3 lakhs. Patient may not be very comfortable with that. तो वो क्या करेगा कि सर आप 5 कर दो, बाकी के आप ऐसे ही freeze कर दो.
Is that where a time lapse might help? Of course, not the cost part of investing into, but selecting those 5 blasts.
Yeah, so time lapse is a totally different topic, but time lapse has shown evidence in only 2 things. One, they don't claim better pregnancy rates. The time lapse data shows that there is reduced pregnancy loss in terms of the abortion rates reduces when you select the embryos using time lapse. The second study that they're trying to do is trying to correlate time lapse data with the euploid status of the embryo.
The first point is same for PGT, right? They don't claim to increase the pregnancy rate, just that.
No, PGT will improve your pregnancy rate in specific groups of patients. So if
but not the cumulative pregnancy rate at the end of all transfers, it's the same.
No. So if you have a patient of 37-year-old and if you are doing a regular IVF, if her pregnancy rate is say 25%, with PGT, her chances of conception are equal to a 27-year-old female. So it basically reduces the effect of age on the cycle. Secondly, with recurrent implantation failure or recurrent pregnancy loss, it improves your pregnancy rate or your live birth rate. So it does, but in a very specific. If I am doing PGT in a 27-year-old female with no evidence of any problem, it does not improve my pregnancy rate. But only in specific groups of patients, it does improve the pregnancy rate.
Well, we had time lapse and we've been routinely doing time lapse evaluation a decade ago. But now you've not been doing it because it really does not give me an idea whether the particular embryo is aneuploidic or no. Many aneuploidic embryos still have a normal growth rate, and time lapse only gives you the normal growth rate. It does not tell me whether the embryo is aneuploidy or otherwise.
Yeah, so I want to do a study. So we just recently bought a time lapse. I'll do a study on time lapse versus euploidy.
No,
because we are doing both.
I wanted to tell you that if it costs 1.5 lakhs and you have 12 embryos, to help you select embryos to biopsy, maybe time lapse might help.
Time lapse might help me in selecting the blastocysts that I want to biopsy, obviously. But
we all know that the most beautiful blastocysts
are
also
abnormal.
become abnormal and the not so good looking are normal. So
खोटा सिक्का है वो.
that ways,
That's what maybe
select
time
the
lapse
best
will help.
embryos, but
So I think this is an ongoing debate and a discussion which we
Yeah.
will
just one question. When you transfer the mosaic embryos, do you do prenatal testing on them?
Prenatal testing is advisable in all patients who undergo PGT.
Even if
Even if you transfer normal embryos, it is highly recommended. It's a part of your counseling that आपको prenatal testing तो करना ही है और नहीं तो NIPT तो करना ही है. So it is a part of your cost or your counseling that you have to do. So it is highly recommended.
Thank you.
Thank you so much. Thank you.
Dr. Sujay, please hand over the memento to Dr. Prabhakar. Dr. Sujay, please hand over the memento to Dr. Prabhakar. And I thank my respected chairpersons for chairing this session. Thank you so much, Dr. Aradhna, Dr. Navneeta, and Dr. Meeta, sorry. And now our next chairpersons for our next session is Dr. Jigna Garasia Patel, Dr. Pratichi Mavani, and Dr. Manisha Jain. Please chair the session. We welcome you for chairing the session, second session. There's a little bit of shuffling of the program because a few speakers couldn't make it to the conference. So our next speaker for today, again we are having a video session by Dr. Sachi Shah. She's from Baroda. The master videos in How Do I Do It. So Sachi, please show us how do you do it.
Day 6, section 6 में रखा है. Just pause it. Okay, good morning everybody. So I'm Dr. Sachi and last year I was a fellow over here and it's been now 8 months that I have been doing TLHs and the confidence which I gained was from sir himself. And every steps, even today, when I do it, I remember sir saying, okay, have you seen the pressure? And have you seen, okay, before entering your, and every time we used to remember sir's voice telling that, you know, you have to do this step, next step, this step. So here's a video. So I've just fast forwarded it because there was a 8-minute session only which was there, and initially this was in month of May when I went back and I was doing. So it used to take some time, which is there, and gradually now I have gained confidence in doing it, and I'm very thankful to sir for teaching me the hysterectomy over here. So So now I have been, initially when I went there, I started with the 3-port technique, but then we didn't know endo suturing. So then I needed somebody to assist me for that. So they knew their hysterectomy from left side. And then gradually I learned it. So I'm doing it now from the 4-port technique only, which is there from the left side. But then the confidence which I got was only from this institute over here. Cutter. Bipolar cutter and monopolar for the colpotomy. This was just initial endosuturing, which I had just taken a knot, and then in the next case, now I am doing the suturing. So. So this is the second surgery which we've done it in the past month only, which is there. And this was a case of previous cesarean section also. So initially sir had told us do easy cases, then go ahead. So that is how we are going ahead.
It's a great feeling, Sachi. You are doing great because we have seen you, how you have evolved.
Thank you so much,
joined
ma'am.
and now you are in a practice. It's a very good thing.
Yes, yes. And still I remember sir's voice telling us, do this, do this, do
And
this. And at times I used to think that if sir would be here, what is he going to do? Once we had come across a case with lot of adhesions also in the POD area. And then he had taught us with the suction only you can, do the dissection. So,
realizing how he was become angry on you when you are doing mistakes.
yes,
but
yes.
It really helps.
Very, very much, yes.
I always feel कि without ऐसे shouting and all, you cannot learn. अगर कोई pamper करेगा तो you cannot become a good student ऐसे teacher. Sorry.
I think sir is not here.
Shaji, the
Hi.
surgery is really bloodless. As we can see, the main advantage of TLH over the other hysterectomy, that it usually causes the less blood loss. And as we can see in both the surgeries, it seems really effortless and bloodless. So really nice work done there.
Thank you. So this is it. I would really like to thank everybody to teach me such a nice laparoscopy surgery, and this was one of my passion to do it, and so I am now here. Thank you so much.
It was really very good, very nicely done.
Thank you, Sachi. Very impressive, and I'm sure Akshay would be proud, but he's in the other hall. But don't worry, we are recording your sessions and he'll watch your video too, okay? And our next speaker for today is Dr. Pooja Nadkarni Singh. She's going to speak on freeze all cycles in IVF. Is it the best? Over to you, Dr. Pooja. And chairpersons, please introduce her.
Dr. Pooja Nadkarni, you know, she doesn't need much introduction. We did residency together, so for me, it's a long bonding. She is the director of Nimaya in 21st Century Hospital, Surat, and she's a very successful IVF consultant.
We welcome you on the dais for your presentation.
ऑडियो नहीं है ये आएगा क्या A very good morning to all of you. Thank you, Jigna ma'am, for the kind introduction. Dr. Jigna has been my teacher. She was senior to me in the same unit, and we've really shared a great bond during residency. And when mom wanted somebody to assist her, Jigna ma'am was the best. And she's with us since the last 16, 17 years, 20 years. So when we started off IVF in Surat in 2006-07, those were the early days of IVF, and there was no freezing at all. We only did fresh day 3 transfers. We did not even do blastocyst transfers. And then came the era of slow freezing, and gradually vitrification came in 2014-15. We were still very hesitant because we were comfortable and we were in the comfort zone of transferring fresh embryos. We were having a good 30-40% pregnancy rate in those times, in 13-14, and we were happy because when you're getting 30-40% success rate, when you have a good number of patients, when you are transferring day 3 embryos, you really don't want to get out of that comfort zone, get into freezing, see what it is all about, depend upon another person who's freezing, thawing. There may be loss of embryos, and initially nobody had the experience of vitrification. But slowly and gradually, since the last 3 years, now we've come to a strategy of freeze all. So we do not do a single fresh transfer at Surat anymore. Maybe 1 or 2 if the patient has no time, if the patient is not staying in Surat and they want to go back, fly back somewhere else. That's the only indication we do a fresh transfer. So let's see what evidence has to say. Do we have a universal license to chill? Yes. The first live birth after frozen thaw embryo transfer resulted from a slow freeze in 1984, followed by vitrification in 1990. Why should one go for FET? Controlled ovarian stimulation with exogenous gonadotropins promotes for multifollicular development, which lead to supraphysiological levels of estrogen and progesterone, affects endometrial development and maturation, leading to advanced histology and advanced downregulation of the progesterone receptor. Advanced receptive phase decreases the endometrial receptivity, embryo endometrium asynchrony, and implantation failure. What are the absolute indications for FET? Surplus good quality embryos, follicles more than 14 on day of trigger, fluid in the cavity, endometrial thickness less than 7 mm or more than 14 mm, previous history of ovarian hyperstimulation syndrome, previous failed fresh transfer, spotting on the day of embryo transfer, serum progesterone more than 0.8 nanogram per ml, difficult ET, PGD, before cancer, chemo or radiotherapy, pooling of embryos in low ovarian reserve, and of course social freezing. What is the freeze-all strategy? Here the entire cohort of embryos is cryopreserved in hyper, normal as well as low responders and transferred in a natural or a down-regulated cycle. The objective of this policy is to place the embryos in a more favorable uterine environment without facing the probable adverse effects of the supraphysiological hormones on the endometrium. There is also concern of fresh transfers with the safety of pregnancy and the birthing process. Advantages: separation of the embryo transfer from the stress and rigors of ovarian stimulation, decrease in uterine stress, childhood and adulthood diseases, more physiological environment, increased receptivity and higher pregnancy rates, less monitoring, OHSS free clinic, transferring fewer embryos, possibility of PGD, and psychological support that more embryos are there. Disadvantages: exposure to chemicals, exposure to extreme temperature and manipulations, long-term studies are not available, increased risk of placenta accreta, macrosomia large for gestational age and C-section rate. In a study by Pittsburgh et al., increased spontaneous abortion rate, but that's debatable, slightly increased risk of pregnancy-induced hypertension. What do studies say? A multicentric study involving 1,508 infertile women with PCOS in first IVF cycle comparing fresh and frozen embryo transfer, they found FET had higher live birth rates, lesser pregnancy loss, and OHSS is less, but higher frequency of preeclampsia. This is another study which compares fresh versus elective frozen embryo transfer, a systematic review and meta-analysis. Here 11 studies including 5,379 patients. Significant increase in the live birth rate was noted in elective FET in overall IVF ICSI population. Higher live birth rate in FET was noted in hyper-responders and PGTA cycles. No difference in normal responders. Risk of OHSS was lower in elective frozen embryo transfer, but there was increased risk of preeclampsia in the frozen transfers. This is a study in 2018 where the cost effectiveness of freeze-all or fresh transfer in IVF in non-PCOS women, and here this showed that in non-PCOS group the freeze-all strategy was not cost effective. This is a SWOT analysis of the freeze-all protocol. Here major advantages is preventing OHSS. Enhanced cycle scheduling, improved organization of the IVF unit are the elements that should not be overlooked. Taken together, these developments may lead to a new era in modern ART, but however, more studies are needed. This is another study. Here, freezing all embryos is beneficial in high responders, but not intermediate and low responders. It's an analysis of 82,935 cycles from ASRM registry. Here, all cases were divided into 3 cohorts. Low, 1 to 5, intermediate, 6 to 14, and higher responders, more than 15 eggs. CPR and LBR were significantly higher in high responders in the frozen cycles than the fresh cycles. It was better in the fresh transfer group in intermediate and low responders. Prospective study, here Marcus Root compared IVF outcomes between fresh and frozen embryo transfers, where fresh ET was performed only in cases without progesterone elevation. IVF outcomes were still significantly better using freeze-all compared with fresh. So even with less eggs, the endometrial receptivity is impaired, according to some studies. In a Cochrane review by Wong et al., where 4 randomized clinical trials were analyzed, there was no clear evidence of a difference in cumulative live birth rate between freeze-all and conventional IVF. The prevalence of OHSS was lower after the freeze-all strategy compared to conventional IVF ICSI. Comparison of outcome in PGS cycles, 1,400 patients were subjected to aneuploidy screening. Either a fresh day 6 transfer was done or a frozen day 5 transfer was done in the next cycle. Clinical pregnancy rate was higher in the freeze-all group. Freeze-all versus fresh blastocyst transfer in women with normal menstrual cycles. Here it did not differ significantly. This is a case at our center comparing fresh and frozen transfer in 2018 to 2022. So if you can see in the year 2018, we did only 174 cases of frozen transfers compared to 745 cases. And now in 2021 and 22, almost 100% cases were frozen and we did not have any fresh transfers. So here the clinical pregnancy rate has increased from 62% to 76%, and I think now I am in the comfort zone of a freeze-halt instead of a fresh transfer. All patients were given either antagonist protocol in high responders and normal responders, or microdose long protocol in poor responders. Trigger was given with agonist in PCOS and normal responders, and recombinant HCG in low responders. We had significantly high success rates in the last 2 years using FET for all. It may be also attributed to switching to only frozen blastocyst transfers in 2021 and 22 compared to day 3 transfers in the previous years. We also did a large number of PGTA cases in 21 and 22. So what are the absolute indications? PGTA, OHSS, day 6 blastocysts have bladder implantation in FET, dual stimulation protocol and embryo pooling. And so let's see what the endometrial preparation for FET we do. To receive a receptive endometrium, HRT aims to mimic the natural cycle. First step is add estrogen to prepare the endometrium and prevent ovulation, and second step is progesterone is added. Cochrane's systematic review concluded that the type and route does not affect success rates. Daily 4 to 12 mg per day. Tablet Progynoa 2 mg 2 BD for 5 days and then 2 mg TDS till the end of the month. Recent RCTs have shown that vaginal progesterone alone was inferior to intramuscular progesterone. One retrospective study concluded that when progesterone is less than 22 nanogram per ml and more than 31 had less implantation rates. So less progesterone leads to lesser implantation. Start injection triptorelin point. This is our protocol. There are different protocols and the results are almost similar. We start injection triptorelin 0.1 mg daily from day 21 of the last cycle or after stopping Primolute and post the pickup. Progynoa 2 mg 2 BD and 2 mg 2 TDS till day 12 or day 14, and endometrium is 9 to 12 millimeter. Do a E2 progesterone on day 12. Start progesterone on the night of the supposed pickup and 400 mg BD and IM 100 mg from the next day. And then we transfer a day 3 and a day 5 transfer. Natural and modified natural cycles can be done, but too many scans and monitoring is troublesome. Safety of cryopreservation. Perinatal outcomes. Large gestational age and high birth weight. Large studies support more than 4 kg and 4.5 kgs compared to fresh transfers. No effect on maternal BMI or parity. Length of feeding does not matter, but now recent studies have shown that the optimum time of thawing a frozen embryo transfer is around 2 to 3 months. If you freeze it for more than 6 months, there is slight decrease in the pregnancy rate. These are the recent studies which have come up. Differently expressed mRNA in FET placenta than fresh transferred babies. SG and low birth weight, less chances than fresh transfers. Preterm birth, FET has less chances of premature labor. Studies from Sweden and Japan highlighted the risk of PIH and preeclampsia in FET. A Nordic study shows that PIH in FET in HRT cycles and not the natural cycles, showing that endometrial preparation with estrogen protocol might have an impact. Cost effectiveness, Rogue et al. Has shown lower cost than fresh transfers, but contrasting studies. And one main reason which is cited that the cost is more. But again, if you're doing a lot of cases, then the cost is definitely lower. To conclude, freeze-all provides a lot of opportunities of increased implantation, especially after introduction of vitrification and increased post-thaw survival. In my clinical experience, because we use antagonist protocol and agonist rupture for most cycles, and we aim at an OHSS-free clinic, we use a FET for all strategy. There's currently an e-freeze trial going on in Scotland and England, which will provide us with further insights. And it is an ongoing debate, and you can still do fresh transfers for low and normal responders. Thank you, everybody.
It was a very nice presentation. Dr. Pooja, I want to ask you that do you wait for 1 month in between? Suppose the patient is hyper responder and you feel that there is fluid and everything in there. So you wait for 1 month in between the FET cycle, or you go immediately after?
So depends. If it's too much of OHSs and lot of eggs, then I give them 1 month of gap in between and do it after 1 month. Okay. That is 2 periods. Okay. And if there's not much and just mild OHSs, I do it directly after.
Immediately after?
Immediately, yes.
Menses. Okay. So you start triptorelin immediately after pickup?
No, after pickup we give Primolute N for 7 days and then start triptorelin, because then we know the number of embryos and blastocysts. Sometimes there may be only one blastocyst, so we might require to do one more cycle. So depending upon the number of embryos we have, we counsel them for a FET or maybe a second cycle of pickup.
And according to you, what's the result? Means you're getting you told that
Yes.
76% implantation rate.
Yes, we have a 76%.
That's very good. Thank you.
Thank you, Pooja.
Any questions? Any more questions in the audience?
I think how Freezol came with a bank vitrification, everyone was an expert at vitrification, and then we relied more on our embryologists to give us good embryos. Do you think with the rules that are coming up with single embryo transfers and just a couple of transfers, the whole paradigm is going to shift towards milder stimulation protocols aiming to achieve only 4 or 5 or 6 eggs probably to just achieve one blastocyst, and fresh transfers will come back with a bang like how vitrification came, because the future we will not be allowed to transfer more embryos.
Yeah, but I think in milder stimulation, if the patient fails, you have to again undergo the entire cycle of stimulation. So for me, transferring one blastocyst or 2 blastocysts from a cohort of 10 blastocysts which I have frozen will make more sense and more cost effective to the patient, and the patient will also not be demotivated if he has that hope that I still have my embryos in the
No, yes,
frozen state.
vitrification, yes. I'm talking about the fresh transfer part. Do you think fresh transfer in the future will...
So it's still here. The fresh transfer is still here. I have changed to elective freeze-all,
Most
but there
of
are
us, me too.
lot of centers doing fresh transfers for normal responders and poor responders. But they might just come back. Yes.
I think freezing and thawing blast is also many embryologists, they are not perfect in that. So I think it will vary from lab to lab what you are comfortable. If your embryologist is that much
So I think I think we should be doing so what I feel that in the lab, like every embryologist aims at first doing embryology, then doing freezing, then doing thawing, and then doing ICSI. But I think one person should be mastering one role. So if a person is in the andrology, he should be doing only andrology for a long period of time. At the same time, a person should do freezing and thawing for the entire maybe their lifetime. So then you're going to master that rather than keep jumping to different things even in the embryology lab.
So I'm asking a question here as an obstetrician. As you said, there are high chances of large baby in PIH. There are anything we can start for prophylaxis of that as an obstetrician?
Yeah, so I also have a larger number of placenta accreta, larger number of PIH cases after we have switched to elective embryo frozen transfers, because I do my obstetrics myself. So I can see that 10% increase.
So if we are an outer obstetrician, we haven't done the frozen embryo transfer. We know that it's frozen because
Yeah.
it's already eaten. So that is anything we need to start. I mean,
So-
the dalisprin or the.
So most of these are also high-risk patients. So they are not only because of the frozen part, but because of all these patients are usually maybe in their 30s and never conceived before, and they have antiphospholipid antibodies and stuff like that. So maybe aspirin or low molecular weight heparin may help, and maybe transferring a absolute natural cycle without estrogen, as the studies say, they might help. But we've not yet tried the natural ones.
Prophylactically, metformin and labetalol, that is not necessary.
No, metformin can be given, and it will definitely help.
Okay, thank you.
Yeah. Okay.
Thank you so much.
Thank you.
For this lovely session.
Thank you, Dr. Pooja. It was lovely having you here. And now we are having our next speaker, Dr. Hemant Kanodia. He's going to speak on TLH in endometriosis. This is a surprise entry, but yes, this Sunday session was supposed to be a mixed bag session. We welcome Dr. Hemant Kanodia. He's from Mumbai. And he's also our operating faculty.
We have. We have pointers for me.
Yesterday we saw his magic. He did a beautiful endometrial resection, endometrioma resection, which was shown in Takshashila Hall. So I'm sure TLH in endometriosis must be really, really tough, and he's going to show us the way to it.
Which one? Yeah. No, there's nothing over there. I don't have this. First of all, let me thank Osama sir for allowing me to speak before him. Thank you so much, sir. So as we all know, TLH in endometriosis can be quite a challenging thing. And similar to this frozen pelvis, it can momentarily and temporarily freeze the cognitive and mental abilities of the surgeon on table if one is unprepared to deal with these kind of situations. So let me run you through a couple of videos which highlight the complexity of the situation and how we try to make them as safe as possible. So in this, normally what the problem is and the fear is there is completely distorted anatomy. So you cannot appreciate the normal anatomical structures. So we normally start our dissection at the level of the pelvic brim for a simple reason that endometriosis never goes above the level of the pelvic brim, rarely goes, never, rarely goes. So we start at the level of the pelvic brim, laser pointer. So here, can't make this. It's okay. So if you can see over here, I'll just speak like this. So you can see over here the ureter we have exposed. That's the first landmark that we try to trace to safeguard the ureter because we don't want any thermal damage to the ureter. So the ureter is traced at the level of the pelvic brim first. The other landmarks that we see for is the psoas muscle. See here I've opened the pararectal space first. You can see the adnexa is stuck to the bowel. I don't go directly on the adhesion. First I dissect below the normal area and then I'm going towards the abnormal area, which improves my orientation of the bowel margin and definitely reduces the chances of injury. Okay. Yeah. So here again you can see we are exposing the ureter. And that's the region of the round ligament which we are cutting. You can see the external iliac artery and the vein. So some people think this is unnecessary dissection in endometriosis, what we are doing. But what we are doing is we are improving our orientation. In hysterectomy for TLH, the first thing is restoration of anatomy because hysterectomy then becomes the easiest part. The main thing is restoration of anatomy before you proceed for the TLH because that definitely reduces the chances of injury to vital structure. So here we are exposing the iliac tree over here, which is one level below the external iliac vein and the ureter. So I divide my landmarks into 4 levels. First is the IP ligament, then you have the psoas muscle with the external iliac artery. Below that you have the external iliac vein and at the same level you have the ureter and one level below in between the external iliac artery, external iliac vein and the ureter is the internal iliac artery. And the first branch here you can see is the ureter, which forms an important part of the parametrium. And in these cases, mostly the parametrium is involved. So if you are not going to expose these structures, you will leave good amount of endometriotic tissue at the parametrium, which can cause a recurrence later on. And here you can see the IP ligament over here and below is the ureter. Here is the ureter, you can see. So this distance between the IP ligament and the ureter, as I was showing in surgery also yesterday was very variable. Sometimes it's very close by as in endometriosis and sometimes it's very low. And here you can see the IP ligament. We always create this window below the IP ligament and bare it before we take the IP ligament. This single step drastically reduces the chance of injury to the ureter at this level is very important. We do it for all hysterectomies as a protocol. So here you can see we are excising the parametrial tissue. So this is all before even we have started taking the uterines at the isthmus. So again here you see my instrument over here. This is a bipolar shearer that I'm using along with the routine bipolar energy. We have modified the tip in such a way, this is just my modification over here, where we can give small burst of energy, create good loose areolar spaces. Actually, we are creating a good safety margin before passing any form of thermal energy. So this again minimizes the damage and the contact time of thermal energy to important structures like the ureter. So that again we are dealing at the level of the uterine artery. That's again the parametrial tissue over the uterine artery which we are removing. The other alternative, like a radical hysterectomy, you can just knock off the uterine artery, flip it over the ureter and do it like a radical hysterectomy, but it's not needed in all cases. Here you can see we have opened the pararectal space, and here we are removing all the tissue in the lateral parametrium or the posterior parametrium over here in this case, over the uterosacral. So those are all the nodules over there. And these normally encase the ureter, and if you leave them like this, subsequently they can grow further, encase the ureter even more, and there are 30% chances that they can cause silent damage to the kidney, which is even unrecognized in many cases, and we do a lot of redo cases which come to us with, probably compromised renal function. Here you can see, as I was telling you, the uterine artery is completely lifted off, and that is the ureter below, the water under the bridge, as you can see. So here we are doing a complete parametrectomy in this case, because the entire parametrium is involved in endometriosis. For this, a pre-op mapping is very important with a good imaging tool like an MRI. Many people nowadays, they are doing very good with ultrasound also, but you need a person who is focused on ultrasound in endometriosis. Otherwise, MRI is the gold standard in these cases. So this is the anterior dissection in the bladder, the utrovesical fold. See, if you're in the right plane, there's hardly any bleeding, as I was showing you yesterday also during the live surgery. So giving small bites of thermal energy, splitting the tissue in the right plane really makes your surgery very easy. This we are on the right side. And here again, see, we are opening the lateral space in between the IP ligament and the round ligament. So you can expose the ureter either through this lateral approach or the medial approach. The lateral approach is usually followed by the oncosurgeons. The medial approach is known as the endometriotic approach, but I think we should not compartmentalize it or differentiate it. Both approaches are good enough so long as your work is being done. So that is the ureter over there visible already. See the ureter below the IP ligament, that's the lateral approach, and that's the obliterated umbilical ligament which I have picked up over there. So it's important to create these avascular spaces before you proceed with the surgery. And believe me, if you follow these steps, your complication rates will be definitely less than what is given in the textbook. I won't say that your complication rates will come down to 0 because that's practically impossible, but it will be definitely drastically low because of the safety margin that you're developing. So here we are bearing the IP ligament again. Here we are doing an adnexectomy or separating the adnexa. See how close the ureter is sometimes to the adnexa. You can't just, put like a clamp or, just put your bipolar over there and pass thermal energy without exposing the ureter. The chances of thermal damage is almost 100% then. So we do an adnexectomy for a simple reason in this cases in the beginning. It gives us a better view and better access to the isthmic region of the uterus, and the anatomy below is much more clearly visible. So that's the pararectal dissection which we saw yesterday also. So the principle is simple, as in any surgery, first dissect the normal area, expose the normal area, and then your orientation of going towards the abnormal area becomes definitely better rather than attacking the central band of adhesion upfront. So here I can already see the anterior wall of the rectum, which is the normal portion, and then I will attack the central portion, which becomes easier because I can see what lies beneath. So here you can see the retrocervical nodule in the uterine torus. And this is what we exactly did yesterday during the live surgery for conservative infertility. So see here we are, now I exactly know what lies beneath rather than not seeing below and just upfront cutting the central band of adhesion. So finally the main idea is to reduce the bulk of adhesion to a pivot point so that your chances of damage to the rectum is minimized. In this case, even if I damage the rectum, it will be a very small rent which can be easily closed with primary method. Please let me know when it's 15 minutes. I can just go on. Please let me know. So here again you see there's not much adhesion at the level of the pelvic brim. So what we can do in this case is we really need not start the dissection from higher up. We can start it a little low below at the level of the ureter. Go in between the ureter and the sigmoid. You directly enter into the pararectal space. or also known as the Okabayashi space, which harbors the hypogastric nerve. So here, the fat, as the dictum is, and as Dr. Puntampekar also teaches us that the fat belongs to the rectum, we just follow that principle, and our aim is to open up the loose areolar tissue in between, which automatically gives us access to the normal planes. This is on the right side that we are accessing the pararectal space. And again, we have completely exposed the levator ani muscle below, and only the central band of adhesion remains. Now see this case. This is a case of total frozen pelvis. Nothing else is seen. In fact, there is some leakage of endometriotic fluid into the abdomen. She is also for a TLH. And see, here we have no option but to start the dissection at the level of pelvic brim, because you can't see anything below. So you have to expose your important markers like the psoas muscle. You can see a huge adnexal mass on the left side. It's literally impinging over the iliac vessels over there, so you have to be very careful. So create your normal planes, again open the spaces. Just don't go directly and try to clamp and remove the structure. First expose the important structure. So you can see the bladder is literally pulled over the fundus, the uterus is hardly seen, and it's the sigmoid which is stuck to the bladder. There you can see the external iliac artery and the external iliac vein. Okay, so the mass was totally impinging on the external iliac vein. So the first marker that I try to visualize, what I'm holding is the IP ligament actually, and posteromedial to that is the ureter. Lateral to that is the psoas muscle. So these are very important landmarks in cases of complex pelvic surgery. These act as your GPS system for navigating within the pelvis. It's very important that you expose them. Here you can see now the complete rectum has been mobilized, and if you do a proper mobilization by opening the loose areolar planes, you hardly damage the nerves supplying the rectum. Yeah, this is a case of a redo case which was operated by open surgery, and they had to leave the procedure in between because they could not proceed. She came for a TLH, and again look at the level of adhesions. So the first surgery should be the best shot at surgery in cases of endometriosis. It should be done by an experienced surgeon with good volume and who is completely focused on endometriosis surgery. Then it gives a real good outcome. Otherwise, these redo surgeries are not only challenging for the surgeon, but a nightmare for the patient also in terms of morbidity. So again, you see over there, I have not gone for the central band of adhesion. The first thing that I exposed at the level of the pelvic brim is the ureter. And then comes my IP ligament. So this is all in a 3D system that we are doing. 3D definitely improves your surgery effort in these cases rather than a 2D. It can be done in 2D, but definitely 3D has an advantage. So see, I have exposed again over here the pararectal space, and then I'm attacking the adhesion over the ovary. So I have a complete orientation of what is there beneath.
Doctor, you have 1 minute left.
Thank you so much. So see how I am opened the normal spaces over here. The ureter is under vision. The bowel margin is clearly identified. And I'm using electrosurgery over here with small burst of thermal energy, which is just splitting the tissue and giving me access to the right planes. So that's the ureter again. And maintain the adventitia of the ureter because that carries the rich supply of blood vessels to the ureter, so the adventitia has to be respected and maintained. So here again we are boiled down to the central band of adhesion, and the surgery becomes very easy. Again another case of sort of a frozen pelvis. This I think was with an ovarian abscess. Again somebody had intervened and left the case halfway through, or they just started and left it, and she eventually developed an ovarian abscess. And you can't imagine how much these patients suffer, the kind of pain that they have when they come to us. So see, this, we had no choice but to knock off. And this is a 34-year-old infertility patient who was, willing to forego pregnancy because of the amount of pain that she was suffering. She said she doesn't want a child, she just wants everything out. Now look at this case. This looks like a normal, routine hysterectomy, previous LSCS. And when we opened the utrovesical fold, we found that there was impinging of fat in the region of the anterior bladder pillar over here on the left side. And when we tried to open that, we noticed a tubular structure below, which normally we don't see at this level, and that was actually the ureter. So just to confirm our doubt, we went retrograde or higher up cranially and traced the ureter in the broad ligament portion. And luckily we were saved because of a technique of, a millimeter by millimeter dissection with small burst of thermal energy. Otherwise we would have cut the ureter over here up front. So that's the broad ligament portion of the ureter just below the uterine artery at the level of the isthmus. So it's very important that you're adept at these kind of dissections if you're doing these cases. So that's the uterine artery just being taken over the ureter, and it gives us access to the anterior parametrium. This is like a radical surgery actually for a benign cause, but you have to do it in these cases. You have no choice in endometriosis sometimes. The ureter has been absolutely lateralized by opening the anterior parametrium, and that's the ureter entering into the bladder.
Sorry to interrupt, doctor.
Yeah.
The time is up.
Yeah, I'll just conclude with my last slide. So that's what I call it, surgical strike on endometriosis. So just as a conclusion, start from the normal unaffected area, that is a pelvic brim. Look for the landmarks that act as GPS in the pelvis. Open the avascular spaces, which gives better access, orientation, and reduces complications. So in short, dissect more. Completely expose important structures like the ureter. Desiccation or ligation of the uterine artery is compulsory at some times. Restore the normal anatomy before final steps of TLH, which is actually the easiest portion. Removal of all visible and palpable, that is haptic, that you can feel, residual disease. Excision with the principle of economic radicalism, that is, be radical towards the disease but economy towards the function of important structures like the ureter and the bowel. No role for supracervical TLH, which is an easy option, but you're going to leave a big quantum of disease behind, to be done by experienced surgeons with special interest and focus on endometriosis surgery. A multidisciplinary approach may be important, with the gynae being in charge. That is very important, because you're the captain of the ship, not the colorectal surgeon or the urosurgeon. They are just giving their inputs, and be prepared to manage the complications. Thank you so much. Final, once more, thank you to Dr. Osama sir for giving me his time. Thank you.
Thank you, sir. Your videos were very scary in the start, but satisfying at the end. Thank you for the nice presentation.
See, I just say one thing in life: nothing is to be feared; it is only to be understood.
That's true, sir. Very, very true.
What
Thank
I
you so
liked
much.
about your surgery is, we being a gynecologist are always scary for a ureter, and you started your surgery with identifying the ureter.
Sir, please, a memento from us. Can I ask Dr. Jigna to please present a memento to Dr. Hemant Kanodia, because then he has to go and operate. That's why we are giving away the memento right now. Thank you, Dr. Hemant. Your videos were very, very impressive, and I'm sure you are a great surgeon. We saw you operate yesterday, and we really enjoyed your surgeries. And now we have Dr. Osama Shauki. He doesn't need an introduction because we all know him. He's world famous. And we are more than happy to have you, sir, here. And he's going to speak on redefining hysteroscopy, the redefinition of hysteroscopy.
Thank you very much.
Welcome, sir.
Are you ready? Okay. All right. Look at the screen. Namaste. Good morning, my dear friends, and welcome to the cavity of the uterus. Welcome to your home. Today, I will surprise you by a new vision. It's not hysteroscopy, it is gynoscopy. Let me give you an advice. You are going to learn how to drive a scooter. So don't be brainwashed to jump for a bullet in field. In every Congress, I am really impressed by the kind of surgery of endometriosis. They cut the ureter. This is what you're doing? So you have to focus. A gynecologist, home is the uterus. Few of you will be Shailesh Puntamakar, will be like Travedi, whatever. But before I start, I want to motivate you by an academic scientific publication came from Harvard Institute of Psychiatry and Neurological Science by a great researcher. William James is the founder of psychology lab in Harvard. He said that the greatest discovery in our generation is not the nuclear power, it's not the internet. The greatest discovery that each and everyone is able to change all his life by changing your mindset. What does it mean, mindset? Everybody, listen to what I say and try to understand it. You are not what you think you are. What you think you are is what you are. Okay, have you got it? If you think you are the most beautiful person when you walk, everyone, wow, she's beautiful. If you are really beautiful, but you feel, no, I'm ugly, and you walk humble, nobody will look at you. So the way you look at yourself will decide how the people look at you. This is number one. Second fact, forget about hysteroscopy, learn this from me. Second fact, inside every one of you, there is another you. Inside every one of you, there is somebody else, stronger, harder, wiser. But I tell you the truth, many people live and die without discovering the one inside. Akshay could discover, okay? But Puntamakar I could discover. Pooja could discover and became a marathon winner. You have to discover what's inside you. I'm not just motivating you by blah, blah, blah. I have the evidence that who are impressed by my talk, they became a winner. This lovely young lady, Sonal Parihar from Jodhpur. She invited me to do a workshop in her hospital, and we had a very good live surgery. And in the operating room, I told her, Sonal, what's your dream? I said, no, don't ask me, sir. I don't want to say it. I said, come on, you want to be the greatest surgeon? President of the Foxy? She said, no. My dream since I was a child is to be a winner of beauty contest. I said, come on. You have listened to my lecture. There is another you inside. I said, so don't bluff me. I am dark skinned, I don't have nice hair, I'm not like those. I told her, think again what I said. Inside you, there is another you. 1 year later, on the internet, I saw this. Sonal Parihar, the winner, Miss Earth and Universe, okay? I think I have the proof now. Okay. What I'm proud of in my life is not to be a great surgeon. No. I'm more humble than what you think. But my pride, I could change life of millions all over the world. That's why I live in their heart. Now we go to the cavity of the uterus. You are proud to be gynecologist. Come on. You are still doing blind procedure. You are taking the biopsy without seeing the cavity. Is any urologist do polyp removal from the urinary bladder by curettage? You are laughing now. See how they laugh about us. So we are much retarded, and up till now we are still using instruments invented 2,000 years ago. Is any specialty in medicine using a tool which is invented 2,000 years ago? The vaginal speculum. Okay? So my message to you today that the biotechnique is not only for the uterine cavity, is to look inside the vagina and the cervix and even extend to the proximal part of the fallopian tube. No more painful examination in the office. Let me, when I want to teach people, I let them share the moments of the real, what's happening in the office. Let us see how the patient coming to your office terrified. My dear friends, gynecological examination is the most unhuman, rude, indecent examination. Imagine a woman coming terrified. Take off your clothes. Okay. This is the first thing. Okay. Lie on your back, open your legs. That's very unhuman. And then a stranger looking for private parts for 5 minutes. Come on. I'm going to change all this. Patient is panic. And when she sees us like that, we are monsters. I'm happy that I surprised you about what you're doing every day in your place. And she is hearing the... Sir, what you will do? Shut up. Open your legs. Are you going to put this? Yes. Why you put the things in me? To inspect your vagina. Come on. Look at this picture. Do you see any vagina here? No, you don't. So, for all over your life, you write the prescription for vaginitis. You have a white discharge. Okay, Simonelia. You don't see anything. Strawberry vagina. We teach them strawberry vagina. You have never seen the strawberry. So it's a frustration for them. Time for change. Time to use the light. In beginning of every ceremony here, you light the lamp. So I'm bringing you the light to explore and see each and every part of the female genital tract. To make vaginal examination accurate, convenient, comfortable, with dignity. You put the telescope into the vagina and you look at the monitor. You are not looking at her private parts. Respect women's emotions. And the patient feels very comfortable. There is no metal things inside her vagina. One more thing. Definitely you have met those patients who came to your office very hesitant, afraid of examination. And you try to put your finger, she scream. So how you put a speculum? And those postmenopausal with atrophic vagina, very narrow, and you cannot put your finger, she scream. How you explore the vagina? Virgins. So, simply in the office, using a 2.9 telescope. 2.9 is less in diameter than the uterine sound. And you go through the valve, no speculum, no teneculum, open the water. Another world. You have never seen this before. For Kishore, for the first time I have the privilege to show your people the vagina. They have never seen it like this before. So you see, this is an atrophic vagina with a typical strawberry pattern of trichomonas vaginalis in a postmenopausal lady. So nobody was able to put a speculum before. You look at the exam, it's so decent, so comfortable. Okay, lips, very famous. Angelina Jolie is over her lips, okay. With the same lipsticks. What else can show the cervix better than that? I am very happy to see the look at your eyes. Oh. Why we don't see it like this? And that's typical mixed vaginitis with the strawberry red color together with the white curdy discharge. Okay. Have you ever seen this before? No, Osama. What is this? Cystic bluish follicles on the portion vaginalis and the lateral follicles. Where is the endometriosis man? Sir, this patient operated 2 times laparoscopically for deep infiltrating endometriosis. He removed everything from above, but he missed this thing. That was causing dyspareunia and pain. And not only to look and diagnose, but also to treat. So Aditi, I'm happy to show you that I'm the first one to introduce the concept of intravaginal endoscopic surgery. Okay. You can drain, cauterize. So, are you happy so far? Yes. Good. Colposcopy. Every doctor wants to buy a colposcope in his office. When you buy a colposcope, you look at the cervix from far away. Hello, cervix. Can you go by the colposcope inside the vagina? No, you cannot travel. Can you see the endocervix? No, you cannot see, which is most of the problem. So, this is the view of the endocervix. As I showed you the lips of Angelina, you can go inside. This is the endocervical glands and mucosa. You can see early CIN, you can see adhesions, you can see Nabothean cyst. IVF people are crazy. They don't look at inside the cervix. They drive the car, the embryo transfer cannula, without seeing how the way. Look by the hysteroscope 2 days before, so you know how to drive your cannula. The most terrible procedure for me in the operating room is not hysterectomy, is not myomectomy, it is dilatation. When I do dilatation, my hands are trembling, okay? You are driving in the dark and push against resistance. Oh my God. You depend on your luck that you are pushing into the proper direction. But my dilators is the softest thing in life. Penny. Penny, penny, penny. Okay? So overcoming narrow cervix or adhesions by the power of water. Enjoy this case of failed hemisphere twice. Before of cervical stenosis, pinhole cervix, hypertrophic endocervical mucosa, and fibrosis at the level of the internal os. Keep your eyes on the internal os and enjoy the hydrostatic release. Now, everybody look at this. It's a combination of hydrodissection and move forward. Look at this. Under full control, full vision, you enter the uterine cavity. And we are in. So no more blind entry, okay? Another issue, how many times family came with their daughter, 10 years, 8 years old virgin with severe bleeding, and there is a polyp in the cervix. Everybody diagnosed the polyp, but nobody is able to touch. In our culture, hymen is a matter of life and death. The family is ready that their daughter lose one eye, but not lose the hymen, okay? In the West, they don't mind to sacrifice the hymen. Even in a young girl, if you cut the hymen, how you put speculum and neck, how you reach the cervix? So I developed the technique of transhymen access. Not because I'm genius, because the Western people didn't think about it. So we can go through the hymen and easily distend the vagina and see the pathology. Can you imagine, Kishore? It happened in my country many times. Girls like this was operated abdominally. They opened the belly, bisect the uterus to remove this little polyp. So I can go by the mini resectoscope, reach the pedicle, and you cut. The satisfaction and feedback of the family after this procedure is greater than a family has a patient with cancer cervix. You did hysterectomy for her. So, because you offer them a solution. Let me move to something more, uterine anomalies. Any person working in fertility, he suffered from patients with congenital uterine anomalies. The incidence of infertile population is 15%. In recurrent pregnancy loss, 25%. So it's huge. The classification of Eshery put forward in 2014 into categories. U0 is the normal uterus. U1 is a uterus with abnormal shape. So you call it dysmorphic. This means abnormal, morph means shape. So U1 is the dysmorphic uterus or infantile or T-shaped. U2 is the most common anomaly of the uterine septum. When both cornea are separated is a bicornate, and U4 is the unicornate uterus. Diagnosis. Diagnosis is easy for gynecologists, but believe me, don't ever read the report of a radiologist. For them, any uterus like this, bicornate. They describe bicornea. But this is the signature HSG in the hand of every patient coming to your office. Sir, I don't know. Some doctors said this is a septum. Other doctors said bicornate. I don't know what's the truth. So it's easy. If the angle between both corneas, this is the angle, okay? If the angle less than 90 degrees, 100% septum. 100% septum. But if the angle more than 90 degrees, it is, I cannot tell, no. Yes, maybe. It could be broad septum or bicornate. So tell her, madam, in that case, I have to send you for a colleague to do 3D ultrasound. 2D is good, but 3D, look at the tissues in between both corneas, okay? It's very obvious this is the septal tissues. And 3D ultrasound is the hallmark for diagnosis. If you inject some water during the procedure, you will have the beautiful view of sonohysterography. So, can you tell me what is the diagnosis? 2 corneas in between. Are there tissues or black space? So it is bicornate. This is the best lesson you get today, all right? So I always say, Kishore, to my students, I perform septum. How much time it took me the septum yesterday? 4 minutes, 20 seconds. But I spent half an hour to study the images of 3D ultrasound before. And I don't allow anybody to do the 3D except my son Yahya. He's genius. He do the measurements for his dad. Dad, take care. The fundus is that. There is no fundal notch. He gave me exact details. So I go, 4 minutes, I finished. Yesterday, it was a risk doing the case in your place because there is no images at all. I depended on my luck. So, my technique in septum, people see the procedure 4 minutes. It's simple, it's easy. It is one of the most technically precise. It's a plastic surgery, like rhinoplasty, like mammoplasty. Let me say it. Yesterday, I told you that embryology say that septum results from failure of resorption of the septum. Embryologically, 2 Mullerian ducts, they come close to each other, they fuse. And then embryology says failure of resorption results in the anomaly. This is bullshit wrong. Nothing goes to nothing. There is no tissue disappear. There is nothing called failure of resorption. If this room is the uterus and that's the septum, when the 2 Mullerian ducts fuse, what you call it septum is actually muscle tissues, belong to the anterior and posterior wall. My theory, embryologically, there is migration of these tissues to go up and down and results in a normal cavity. So instead of saying failure of resorption, it is failure of migration. Same like undescended testes. I'm more exaggerating. I'm not meaning you understand. I mean undescended testes also it migrate. So it's the same. So failure of migration results in this anomaly. I prove it by my videos. The technique, distend the uterus, achieve proper stretching. How much pressure, sir, to distend the uterus? There is no number. It depends, one uterus different than the other uterus. It depends on the leakage. But keep it under stretch and look at my hand. Move the very steady hand from one side to other side. Just touch the tissues. Touch, don't cut. And it will retract. Saumia. When tissues retract, your eye should be eagle's eye. You appreciate how much retracted up, how much retracted down, and you calibrate. Calibrate by millimeter. It's a millimeter up, millimeter down. Keep looking to the ostium every now and then. This is your landmark. This is your GPS point to adjust. And this is the final view. When both, I can speak 2 hours about this video. Both tubal ossi at the same level. And this is the real time of the procedure. After surgery, we confirm cure, correction by repeat hysterography. Before and after. That's the way it should be. I did teach everybody in India here. They do septum excellent. So when I told Akshay, where are the cases of the septum I do? Sir, everybody is doing it correct now and very well. They don't need you. I am happy when you do it better than me, all right? But unfortunately, 1 year ago came a publication from Europe. Blonde, blue eyes. And they say to everybody, Osama Shauki is crazy. Septum should be excised, removed. What Osama is doing is just touching. He is not curing the case. And every time I come to India, I receive questions from Osama, what's your opinion about the paper of Stefano Betoki? I feel embarrassed to say it is ridiculous. They are doing the old Strassman procedure of excision. My theory that this septum is muscles of the anterior and posterior wall. Listen to the very romantic comment I say. Septum surgery continue the unfinished job of the embryology, okay? Embryologically, the septal tissues migrate up and down. So this was not done. So when you touch, you give a chance for the tissues to go to where it belongs. So you are just continue what was never been done by that. So how can I reply them? I said, look at my videos. Look at this. Everybody look how the tissues retract. There is no sawamia. There is no residual tissues to remove. And at the end of surgery, you have clean, flat surface. Look, Dr. Amal, look at the retraction. Puck, tissues retract. So I don't have paper to show you or to publish. I have the video to show that my concept is correct. Okay. Now we go to Asherman. This case was in Life Care Hospital in Indore, Dr. Brajbala Tiwari. Patient has total agglutination of the uterine cavity, and she was prepared for surrogacy. Dr. Brajbala was here yesterday, and I tell you what she said. This case was done 2 years ago. It's a combination of hydrodissection. Look at the release of the tissues here. Look at the release of the tissues. Gradual, gradual. Some point appear. Look at this, Milland. Look, Milland of Surat. I'm just showing off. I remember every name, okay? Look at the release. Look here. What is happening now? This is the ostium. This is one ostium. This is before surgery, and this is after surgery. And Dr. Brajbala Tiwari yesterday told me, Osama, the lady has twin girls after successful IVF. Usually after Asherman, the cavity will collapse again, all right? Because the endometrium is still dead or weak. So you give it a chance to regrow. In this time, you have to separate both walls of the uterus. So I show you how to put a Foley's catheter. This is under vision Milland. Nobody have shown this before. To see how the Foley's catheter is kinked inside, under vision for many benefits. That you can readjust the catheter. You can calculate how many mLs of saline, because if you put too much, people ask me, how many mLs, Osama? If you put too much, patient wake up from anesthesia with severe pain. She will not tolerate the balloon. If you put too little, it will slip. So here, under vision, and you confirm proper fitting of the balloon inside. So I finish with fibroids. The classification of fibroid according to the FIGO, they put them into 7 categories. Type 0, when the whole myoma hanging inside the uterine cavity attached by a pedicle. Type 1 is a submucous fibroid with more than 50% bulging into the cavity and less deep. Type 2 is more deep intramural with less than 50% bulging into the cavity. You see here, most of the myoma is intramural, less is bulging. Type 3 and type 4 are the most important for Puja and for IVF people because they are hesitant. Does this affect implantation, yes or no? It is touching the endometrium. And they are afraid to do any surgery and disturb more. No answer about that. But I can remove it very nicely from below, as I show you, without any damage to the tissues. Type 3 and type 4 is intramural, but type 3 intramural touching the mucosa, the endometrium. Type 4 intramural touching the serosa. When it starts to migrate out of the serosa is type 5. When it bulges more than 50% out of the serosa, type 6. And type 7 is equal to type 0, but subserous pedunculated fibroid. This is the view by hysteroscopy to show a submucous fibroid. I give you some tips. When you have a myoma inside the subserous, and you do laparoscopy, you can inflate the belly and create the space, and still you can move around the myoma. There is a space. But inside the cavity of the uterus, you have a restricted space. That's why I say it's more difficult to do myoma resection than laparoscopic myomectomy. So you have to increase the pressure and explore all the uterine walls till reach the pedicle of the myoma. Again, I can speak 2 hours, but I stop now and show you the technique of myoma resection. Create the space, achieve proper uterine distension to allow you to move around the fibroid, push the electrodes forward, look at my hand, electrodes forward, squeeze the myoma between the electrode and the uterine wall, so you stabilize. And then with the working element, pull the electrode back. Listen, with the working element, pull the electrode back only halfway, only halfway. If you pull the electrode back all the way back, the tissue will hit the lens and you will not see anything. So pull the electrode halfway and then all system out, okay? Electrode not all the way back, halfway and then all system out. Conclusion of the procedure, when you reach this layer, the myometrial layer, fibroid is solid white tissues, myometrium is pink interlacing muscle fibers. Training for myoma resection is not easy. It requires long learning curve. And this is the end of the procedure. If you have a bleeding during hysteroscopy, don't worry at all. When I hear a speaker talking about complication of hysteroscopy and says bleeding, I know that this man have never done hysteroscopy. Bleeding is not, there's never complication of bleeding. The only problem with bleeding, that this little blood with the fluid distension, everything is red. You cannot see well. So the purpose of hemostasis here is not to save the patient life, but to see better. So this is the technique. You see the mouth of the bleeder? Laparoscopy cannot show the bleeder like this. You can see the mouth of the bleeder and you touch. Again, the purpose is to achieve hemostasis and maintain clear fluid distension view to be able to continue the surgery. This is after removal of the fibroid. If we have a small myoma like this is referred from IVF center, and they said, Osama, take care, the patient has poor endometrium. So if you use the resectoscope, electrocautery will inflict more damage. So here, you use the scissors. Scissors is not only to cut. Cut, elevate, retract, and dissect. So the ergonomics and the skills of scissors in hysteroscopy different than in laparoscopy. Few people teach this. You should learn how to, Aradhana, to rotate, push, and then cut. And this is the final view. Okay, still more creations coming. I have only 2 slides to show you innovative ideas. The guidelines and the textbook say that hysteroscopy for myoma is suitable only if the myoma bulging into the cavity. So what about if the myoma high up? What to do? Like this one, type 6. I'm sharing this not to show off, but to tell you in some circumstances you have to innovate. This patient is infertile. She did IVF 6 times in Belgium, in Saudi Arabia, in my country, all failed. The only pathology, there is a fundal myoma around the cricket ball size. So every IVF center said it is not touching the cavity. And after 5 times failure, they decided to do myomectomy. But the patient had a bad surgical history with multiple 6 times laparotomy, frozen pelvis. We don't have actually competent surgeon like you or like Hafiz or like, so nobody was able to remove this myoma. They opened the belly and they closed it. They said unreachable uterus, all right? They sent it to me. According to the paper and guideline, there is no way to remove it from below. But you know, I'm sure you have been in this situation when the patient come to your office, sit in front of you with tears in eyes, said, "Sir, I had a dream and I'm sure you are the one who will cure me." You feel crushed. You have to help her. So I said, I will improvise a way. I go by the scissors. I told her I'll do it in 2 sessions. Session 1, to go by the scissors, cut into the fundus. This is the fundus, okay? Should I be afraid of perforation? No, because above me there is a cricket ball myoma. So I cut till I hit the myoma, I open a window and send her home on misoprostol for 1 week. So what will happen? Contraction of the uterus. This is the scissor part, cut the capsule of the myoma. Do you see the myoma behind the curtain of the capsule? Okay. So the myoma was exposed, but still it is very high up. I cannot reach by the resectoscope. I want a way to bring this myoma into my playground, to bring the myoma from interstitial subserous to come into the cavity. Look at this trick, Prubakar. Look. Passion let you make miracle. Prubakar was a chest surgeon, and now he's an IVF man. So this is the capsule. And now this is the view. I could expose the myoma, but Kishore, still it is unreachable. Okay, this is my before last slide. Share with me any idea how to bring the myoma down. Okay, this lady is genius. She said, screw. There is no laparoscopy screw. There is no hysteroscopy screw. Your idea is excellent. What? I tried abdominal massage, I tried squeeze, but it doesn't come down. But your idea is correct, screw. So I told the nurse, bring me the laparoscopy myoma screw. So the nurse said, sir, but you don't do laparoscopy. I said, bring it. And then I dilated the cervix, inserted hysteroscope, laparoscopy myoma screw side by side, like this. And that's the magical part. Milind, can you imagine what's happening? That's a myoma screw, 5 meters, side by side. Screwing the myoma, fix, and pull down. Sir, this is not laparoscopy, okay? Don't get confused. I am inside my home. You understand the words of the music? It says bringing life, enjoy life. Fix and pull down, until the myoma is almost delivered into the cavity. It's almost now intracavitary. After that, the section was done. This is the myoma bed. Can you imagine? You see, it's very nice, very clean. No charring. This is the myoma bed. In laparoscopy, after they remove the myoma, they suture. But here I cannot suture. How you think it will heal? It's very easy, very simple. When you decrease the fluid pressure, look what will happen now. The edges will collapse, coapt. Look at this. Slowly, slowly, slowly. And then she got cured and she got a successful IVF. I want to go fast. Unhysterectomy, don't remove the uterus. While every surgeon in India wants to remove the uterus, I want to keep it in. Okay? The incidence of hysterectomy is very high. The uterus is a coconut, and the lining endometrium is the cause of bleeding. My technique is to shave the endometrium only. Unhysterectomy. I don't know why Akshay didn't bring cases like this. I could have said, very nice. It's 10 minutes procedure. Women go home. No drop of blood. Amenorrhea. Even if she has a fibroid. The fibroid itself does not bleed. If you remove the endometrium, the uterus will shrink. So you can see shaving all the way down till the level of myometrium. This is the myometrium. finishing the posterior wall, going to the lateral wall. This is real-time video. I edited it into 4 minutes, however, it is 10 minutes. Then resection is that you see the myometrium, only the fundus is remaining. This is the most difficult part, is the fundus. You shave it from side to side. You can never do perforation unless you insist to operate without vision. If you see well like this, look at the endometrium, like potato chips. So the woman either has amenorrhea or will be little spotting instead of bleeding. That's almost the fundal view. Look at the cornea this side. This is the most dangerous part, very thin. Save the uterus, don't remove the uterus. Before I leave you, I bring you new ideas by gynoscopy. I don't say hysteroscopy. Enjoy this technique. Hydrostatic dilatation of the fallopian tube. Sometimes the obstruction is just some mucus, some little debris, so this cannon balls, it goes through the ostium. I enjoy the play. So actually my nurse say, sir, okay, you finished. Why you continue working? I tell her, I am happy. I want to play more. So I start to push more bubbles and arrange them. Look at this. Look at this coming part. I arrange them in a row. Do you feel, Milan, that I'm in what I'm doing? And I tell them, go, go, go. Yes, one by one. One by one. Pooja is happy. Thank you. You make my day. Last slide. Every gynecologist do laparoscopy and methylene blue. Okay, you see the spill of the methylene blue, but you don't see the journey. I will show you the journey. Methylene blue test, retrograde. Inject. Now. Look at this. Look at it. This test for the fallopian tube function, the uterotubal peristalsis that pull the dye from the cavity to the inside of the belly. So for the first time, we have a test for the function. Aradhana, when you inject the dye and look by the laparoscope, it is your positive push that showed the spill. But in my technique, it showed the uterotubal peristalsis. And I have complete lecture for this, showing also a very amazing phenomena. You know, Pooja, we give induction of ovulation and we do folliculometry and we see that the most dominant follicles on the left side or right side. And when I do this technique, you see the dye going in, and at the middle, change direction towards the dominant follicle side. So the hysteroscopy has amazing applications. You explored only 1% of it, only 1%. Please, believe me, you are a gynecologist, that's your home. You have to save the uterus, don't remove it, remove only the endometrium, remove as much as possible myoma that causes bleeding, which are mostly submucous. You don't need laparoscopy for that. Don't be aggressive toward the uterus. And at the end, I want to say, always I finish my lecture by saying you're the most beautiful people I met in my life. But today I will say it and I feel it from my heart. Thank you very much. God bless you. Thank you, Kishore. Thank you, Akshay, Aditi, Pooja. God bless you.
So we are speechless.
Thank you, Osama sir.
Thank you, sir. Thank you so much.
Questions? Anybody wants to ask?
Yes, Aradhana. Yes. You wanna know all the secrets today? Okay. I make the dye very concentrated, very concentrated. You have inflow and outflow. I inject the dye from the outflow. If the inflow pressure is high, when you inject the dye, it will be diluted quickly. If you want it to be thick like this, reduce the inflow and inject very concentrated dye, so you will have this romantic view of the dye going like this. I also developed something amazing. I put on the dye, I would love to show it, I put on the dye some antibiotic powder. The antibiotic powder is particles, nearly at the side of the sperm. Okay? And I shake slowly. If you shake well, the particles will dissolve. And then this suspension I inject very slowly. So you will have amazing. You see the particles looking like sperms, okay? Swimming inside. And when they come near the ostium, amazing phenomenon. They suck. You see this particle suck. It's not pushed, it is sucked, which proves the uterotubal crystallis mechanism for sperm transfer. Stay together and I'll show you more and more amazing things about the uterine canal. Thank you.
I thank our respected chairpersons for chairing this session. Sir, could we have a group picture like yesterday?
Yes. Every speaker take the picture here, and this is stupid. The fun started with the beautiful people. Let us go here. You go there. I want them in the picture, not me. Okay, everybody stand up. Show you they're happy. Smile is the cheapest makeup to make you beautiful, okay? So smile, Mr. Chairperson. Everybody in the picture? Yes. The rule of a group picture that the beautiful one in the front and the more beautiful in the back. Okay, everybody smile. Mr. Photographer, you have to smile also with us, okay? Hands up. Yes. Hands up. Okay, thank you. Wait, one more. Okay.
Thank you.
It will be on the Facebook on my page, okay? So be prepared, it will be scandalous, all right?
Thank you, sir. It was mesmerizing as always. Thank you. Dr. Sujay, can you please give the mementos to our respected chairpersons? Dr. Sujay, Dr. Nabila, please give the mementos to our respected chairpersons, Dr. Jigna, Dr. Pratichi Mawani, and Dr. Manisha. And now we go on to our next exciting session of debate session. I invite our respected chairpersons, Dr. Prashant Koti sir, Dr. Vidya Sangare. Are they here? Yes. Welcome, Dr. Prashant Koti sir. Dr. Vidya is here? No. Okay. Dr. Quresha Qureshi ma'am, please chair this session. And Dr. Dinesh Baldania, please come in front. Please chair this session. Dr. Prashant Koti sir, he's a consultant, OBGYN and infertility specialist practicing at Palghar, senior gynecologist. Dr. Quresha Qureshi ma'am, she's senior consultant OBGYN specialist practicing at Killa Pardi in Pardi Hospital since more than 30 years now. I welcome you, ma'am. Dr. Dinesh Baldania, he's our consultant at Valsad 21st Century Hospital. Welcome, Dr. Dinesh. And now we would have our debate topic today on, first topic is on single embryo transfer. So we'll have one person talking for single embryo transfer and one doctor speaking against single embryo transfer. So should we start the debate? Dr. Munjal Kapadia. So Dr. Munjal will be our first speaker for today and he'll be speaking for single embryo transfer. Dr. Munjal Kapadia is consultant infertility specialist at Namaha Hospital in Mumbai. He's also a consultant at OBGYN and infertility at Navsari. So I welcome you, Dr. Munjal.
AGR. USB-C? Yeah. No.
And we always have a moderator for this. So I would ask Dr. Vaibhav Kapadia to do the moderation. Welcome, Dr. Vaibhav. He's Dr. Munjal's elder brother.
मेरा यूज करना है? It says connected here. So yeah, it's come. So can we start? Are we ready to go, Aditi? Okay, so after Dr. Shawky's talk, it felt like we've all watched Sholay for the first time. Following him, welcome to RGV Ki Aag now. Nothing compares to the original, but today we're going to speak on single embryo transfer. I'm going to speak for it. The problem with debates, and even when I was given the topic of single embryo transfer, was that it compartmentalizes the speaker. It makes it seem as if I'm only for single embryo transfer, and Vaibhav, who probably is going to follow me next, is against single embryo transfer. Dogmatism in medicine is not warranted. The problem with even certain senior speakers, even with the younger generation coming in, is a certain level of stubbornness that has crept in. I will only do laparoscopic surgery, or I will only do vaginal surgery. I will only transfer blastocysts, or I will only transfer single embryos, or I will only transfer 3 embryos. The era of that has gone now. The importance, even with the debate here, is now to understand that you have to tailor your treatment according to the patient in front of you. The time you start following certain dogmas and become stubborn is the time you start learning, is the time you start changing your practices for the betterment of your patient. So although Dr. Kanoja wants to remove all uteruses and Dr. Shawky wants to keep all uteruses, most practical doctors, most people in clinical practice lie somewhere in the middle. You remove the uteruses that need to be removed and you keep the uteruses that deserve to be kept. So in that spirit, we'll talk about single embryo transfer. In 1981, the first report of IVF twins was published, and thereafter, in the next few years, abundant reports followed, and from that day onwards, multiple gestation and IVF became conjoined. Between 80 to 99, there was about a success rate of 20% when a single embryo was transferred, which started to go up as you started to transfer more and more embryos. Multiple embryos were transferred to maximize the pregnancy rates. Thus began the debate surrounding the ideal number of embryos to transfer, a debate that continues till today. This is a more recent a study that was published in August 2016. I've kept this slide rather than historical slides because by this time blastocysts, etc., started to be transferred more than cleavage stage embryos. And if you see that even by transferring about only 2 embryos, the chance of multiple pregnancy goes up to about 42 to 43%. With multiple gestations comes a host of problems for the mother and the neonate. For the mother, it's early or late fetal loss, other than the medical disorders, but most importantly, preterm birth, cesarean delivery, postpartum bleeding, and very, very important, parental stress. For the baby, congenital anomalies, all the problems that come with preterm delivery, from palsy to hyperbilirubinemia to sepsis to everything. But importantly, long-term disability and perinatal mortality.
Between 98 to 2011, there was a 29% decrease in the number of multiple gestations, about 33% decrease in higher order multiple gestations. But even today, 36% of all twins and 77% of higher order multiples are still due to ART. The annual expenditures for iatrogenic preterm deliveries around the world is about $26 billion. And for that reason, different countries have different strategies to curtail this. Some countries have laws, some countries have guidelines. That is what you should pay attention to. If you see, Germany, United Kingdom, and the Nordic countries have laws. United Kingdom and the Nordic countries have laws about how many embryos you can transfer. Germany has how many embryos you can culture. Despite all of this, if you see the United States, which only has guidelines, our country does too, the rate of higher order multiples is twice that of Germany and almost 10 times that of Nordic countries. Elective single embryo transfer is the intentional transfer of only one embryo when there are multiple good embryos available to transfer. They should be differentiated when the condition is such that the patient has only one embryo for transfer. In 1999, the first study was done to evaluate single embryo transfer. They had good prognosis patients. They randomized women less than 34 years to either single or double embryo transfer. The implantation rate was the same. Ongoing pregnancy rate was 35% higher in the single embryo transfer group, and multiple pregnancy rates were dramatically lower. A very important part you have to understand in elective single embryo transfer is not pregnancy rate per cycle, but it's cumulative pregnancy rates. This will be of importance as we go later into the presentation about counseling your patients about what exactly constitutes success in IVF. Patients were randomized to either single embryo transfer, one fresh and then after a frozen and thawed one, or a double embryo transfer. There was no statistical significant difference between the live birth rate when comparing DET to a cumulative single embryo transfer, about 43% to 39%. The rate of multiple births, however, was significantly less, 33% in the dual embryo transfer and less than 1% in the single embryo transfer. In efforts to minimize the medical and financial risks of multiple gestation, different countries have different laws. This is Belgium. This is their 2009 policy about financing IVF cycles. And if you'll see, even up to 36 years, in the first attempt and second attempt, it's mainly single embryo transfers. We won't go into the details of all of them. ASRM also has certain guidelines now. This was the 2017 committee opinion. And when you have euploid embryos, whether you are 40 or 41, less than 42, whether it's cleavage stage embryos or blastocysts, they suggest single embryo transfers. The United States has been the most non-cooperative or non-accepting of single embryo transfers compared to the other developed nations. But even recently, you've seen that above 40 age group, you've seen a sharp uptick in single embryo transfers even in the United States. So why are there global variations in the uptake of single embryo transfer? There are many reasons. There are reasons why people prefer dual embryo transfer over single embryo transfer. One of the most important reasons is perceived higher success by patients and by clinicians of dual embryo transfer. But even more important, I feel, is this. It's the reporting of success rate per cycle in league tables that makes us doctors, even in India, transfer more than one embryos, sometimes even as many as 4 or 5. There are many social reasons also. We have patients who come in and say, oh, I'm spending so much money, I want the success rate, I want higher success rate, even if it's more than about 5% more, I want to go in for multiple embryo transfer. We have patients coming in who desperately want twins. For some reason, they think that twins is not a complication. They think twins is cute. They want to put it on Instagram. They have dreams of having twin strollers, etc., etc. That's where counseling comes in. Very, very important, even in our country, is economic. There's unavailability of insurance coverage and poor public funding of ART. In cases where you'll see in countries where elective single embryo transfer works and it's well accepted, it's because there is good counseling. There is the availability of good labs. Prabhakar mentioned at his excellent talk this morning about how your lab has to slowly grow into a lab which is capable of consistent blastulation. It has good cryopreservation facilities. A very, very good IVF lab now should almost have a 100% success rate when it comes to vitrification and freeze-thaw of embryos. You shouldn't be losing embryos at all. If that is the case, single embryo transfer is good for you. The second thing is national guidelines.
good national guidelines and implementation will also help to start the process of single embryo transfer. Availability of insurance coverage and funding, I don't know when that will happen. When that happens, patients will be more accepting of the fact that they can wait and do subsequent transfer cycles so that they prevent multifetal gestation. A very, very important thing that people tend to ignore with twin gestations or multiple gestations is the economic and psychological impact it has on families. 22% of mothers of multiples had parenting stress index scores suggestive of severe stress, as compared to 5% of mothers of IVF who have singletons, and 9% of mothers of naturally conceived singletons. Now, I don't know, I have great kids, I never had any parenting stress, but if you see some of the rascals running around Nama Healthcare, I attest to this statistic. And I don't have twins, but we can ask, I'm sure Pooja and Prabhakar will be, the kids are now grown up. But that period of time when they are about 1 or 2, I mean, they're doing very well. But in our country, a lot of parents also have a lot of financial stress. School fees are going up, college fees. If you have 2 daughters, people think a lot in our country. And that is not factored in just for that small moment of immediate success. If you see the statistic, this shows the acceptance rates of SET versus DET. If your center has matching SET and DET success rates, still people prefer dual embryo transfer, even for that slight increase. But when you start telling your patients that with DET you will get 1% better result also, the uptake of DET goes up tremendously. And once it's 3% or 5% difference, there is no comparison in patient preference between SET and DET. So this is where counseling comes in, handy. If you see the left pie chart, that is the patient preference for DET and SET or singleton or twin or triplet gestation before they have been counseled about cumulative pregnancy rates and about complications of multiple pregnancies. You'll see the amount of people who want twins is quite high. There's even a small amount of, silly people who want triplets. I don't know why. After education, you see that the amount of people who want twins has gone down and absolutely nobody wants triplets, and rightfully so. Ultimately, it's all about the money. Cycles financed by the couple were less likely to utilize SET than those covered by insurance. In the United States, states that have IVF insurance coverage laws have fewer embryos transferred. States which have mandated IVF coverage laws have fewer high-order multiple births, fewer preterm births, and fewer low birth weight infants. A very, very important thing to remember is that a modest increase in the price of an IVF cycle was always offset by downstream savings from neonatal healthcare at 1 year. There are great studies online now about newer advances in reproductive medicine and how it's helping people do selective embryo transfer. So I would urge you all to research this. This is from Fertility and Sterility. This is very recent, 2020. It's about elective single embryo transfer rates in the era of PGT-A mainly. And it says in the setting of improved success rates of ART, efforts are being made to decrease the risk of multiple and subsequent neonatal morbidity, and a major application of these efforts is to utilize elective SET when appropriate. This is from Cochrane. It says, while live birth and clinical pregnancy rate was lower following SET compared to DET after a single fresh cycle, there was no difference in the overall live birth rate and cumulative pregnancy rate following consecutive SET versus a single cycle of DET. These are the ASRM and SART practice committee guidelines. It says the elective SET is excellent now, most appropriate for those with a good prognosis, where the age is less than 35, when you have more than one top quality embryo available for transfer, whether it's your first or second treatment cycle, you've had a previous successful IVF pregnancy, etc. However, they've even expanded it now to saying even if you're close to 40, when you have more than one good blastocyst, selective embryo transfer can be done. Very, very important thing is this. Reducing patients' financial burdens for IVF through insurance coverage or risk-sharing programs have shown to improve patient compliance of SET. Of course, everything is not rosy. As Vaibhav will now point out after this talk, that indiscriminate application of SET will bring down live birth rate in less than optimal patients. And given the high cost of everywhere, it's all about public funding. Once you have public funding, you can have safe singleton pregnancies after IVF. Multiple advancements in ART now with embryo cryopreservation, going to blastocysts, extended embryo culture, good centers which do PGT-A, assessment of non-invasive biomarkers from spread and culture media, that needs more work. artificial intelligence, and again, as Prabhakar mentioned, time-lapse embryo monitoring, we have it, but we haven't found it useful to increase live birth rates. We mainly use it for taking videos for presentations, such as these, which is the truth. Clinics which have great chromosomal screening, and this is like a dream scenario where you would have all your embryos tested. You have lots of blastocysts, even if you have a few. When it comes to a stage where you can actually test for euploid embryos perfectly and in a sustainable way, in a cost-effective way, you will see that there is no difference in live birth rate when you transfer a single euploid blastocyst versus an untested two blastocysts. And you will halve your multiple pregnancy rates. Does anybody know what the symbol is on the left? Anybody? Anybody with raised hands? Nobody. Anybody knows what is open source AI? So open source artificial intelligence is a new website. Microsoft has just funded it with $10 billion. It is known as ChatGPT. You may have read it somewhere. So ChatGPT is an online platform where you can ask any question. It scans the entire internet, and it's amazingly lifelike. It's almost human, and it gives you answers that you couldn't believe. So when I was making a slide about how will AI help IVF, or how will artificial intelligence help us in single embryo transfers, I said, why should I do the research? Let's ask artificial intelligence itself. So if you see on the right, that's a screen recording from my phone 2 days ago. So it said, how is artificial intelligence helping IVF? And this is real time. This is how quickly you'll get your answer. So according to AI, it will help in embryo selection, hormonal prediction, culture optimization, predictive analytics, monitoring and tracking of pregnancy cycles. Everybody make an AI, your ChatGPT account today and try this. It's not just for this. It's a lot of fun. You can ask it all sorts of nonsense, as I'll prove to you in a little bit. Also, this was taught to me by my kids. My kids are using this for homework now. So be very careful. If you have kids, please don't teach it to them. This is my niece doing her project on iron deficiency anemia. And all her questions have been answered by AI. Her teacher doesn't know anything. Okay, so the same way I asked the ChatGPT website how artificial intelligence will help in single embryo transfer. It uses machine learning algorithms to predict the embryo most likely to give a successful pregnancy. And it predicts the best time for retrieval and transfer. Another thing that you can ask it is that if you have a particular author that you like, you can ask them to give you an answer in that sort of language. So you can say, explain to me IVF in Harry Potter style. Or you can say, explain to me IVF in Shashi Tharoor style, and the answer that you will get, it will mimic it. It's scary how real it is. I ask the question now that's on everybody's mind. Is artificial intelligence going to make doctors redundant in IVF? Let's see what our future masters have to say. I'm just going to let you guys read. It is unlikely to make doctors redundant in the field. Still dependent on human input and expertise. Treatment plans still need to be made by a doctor. Emotionally and psychologically taxing on patients, and the role of doctor as a counselor and support system cannot be replaced by AI. Furthermore, AI is not this is just a recording from my phone. It's actually this quick. In conclusion, AI is not going to make doctors redundant in IVF, but rather it will assist them in making more accurate and data-driven decisions. I don't trust it. This is exactly what I would say to somebody who I was going to take over. So like I said, elective single embryo transfer is not for everybody. However, reproductive medicine should aim for the gold standard IVF outcome to be a singleton term live birth pregnancy with elective single embryo transfer. I thank you all for very patient hearing, and just for fun, I asked the ChatGPT bot, please explain, can you write me a poem about IVF in Shakespearean language? And this came up in like 3 seconds. It said, a seed egg joined as one in a dish before the journey is begun. I'll just read the last verse. And when at last a child is born, we'll hold it close and keep it warm. With gratitude and love, we'll say, thanks to the IVF, which led the way. Thank you, everyone. I cede the stage to Vaibhav. Can I remove my iPad? Thank you.
Yes, and now we'll have Dr. Vaibhav Nadkarni speaking on against single embryo transfer. Let's see what Vaibhav has to say.
Good afternoon, everybody. When Dr. Aditi, about a couple of weeks ago, told me my topic, it was a debate, and I was very excited. You know, debates, I've been good at them since childhood, and I remembered my school debates in Vallabhashram, and then I saw the name opposite me. We all know Scissor Tongue. And then I went into depression almost. I could not believe. And then today I heard him and speak. In fact, when you know, there are people you grow up with and people who are already grown up when you are born. And when you see them grow further and you're still that small child, and Dr. Bunjal and Dr. Vaibhav are, in fact, I was named after Dr. Vaibhav Kapadia. So well. So, single embryo transfer. We are in a country where 60% of our population lives in the rural area. And about 4,000 IVF centers have registered in the ART law and the National Commission. And I think a lot of them are in the rural areas. Talking about single embryo transfer, that is the way forward. I'm 100% sure that there'll be a time when we will all be only doing single embryo transfers, and that is all we dream of. But I plan to get my patients pregnant in this life. So, here is me, Dr. Vaibhav. The implementation of single embryo transfer policies has been ongoing since a Finnish study highlighting the risks and complications that can occur as a result of increased multiple pregnancy rates. This is now a common practice in Sweden, Turkey, Belgium, with other countries such as UK, Australia, Canada, and the US showing increased preference for single embryo transfers over double embryo transfers. I had a patient about a couple of months ago. She was from Daman, so UK passports, and they came to me saying, we have failed 4 IVF cycles. I was like, okay, tell me your history. She said, I'm 36 years old. I have a daughter who's 7 years old. I said, how did you fail an IVF cycle? She said, I don't know. You see my papers, you tell me. And I saw that she had undergone 2 retrievals. Both of them were pretty mild. So about 7 eggs and 3 embryos retrieved, 2 blastocysts, and single embryo transfer each time. Both failed. She was 36 again, reiterating the fact. The second, again, cycle, 2 embryos, 2 blastocysts, frozen, thawed. No PGT, but yes, transferred single again. So 4 transfers, 2 pickups, all failed. Did not work. No report that was abnormal. They were advised PGT-A, and they wanted to come back to India. Now, why did they want to come back to India? Is because they knew, they understood that India is a country where it is allowed and to transfer more embryos, and they were insisting on the fact that I transfer more embryos. Even if they had not, I would have still transferred more embryos. The chance of a multiple pregnancy is significantly increased when comparing double embryo transfer as against single embryo transfer. But is a blanket policy of a single embryo transfer suitable for everyone? Meta-analysis showed that in women with a good prognosis, those who had a double embryo transfer, we all know that, had a statistically significant live birth rate. However, when a subsequent SET was performed, like a cumulative pregnancy rate, similar live birth rates were formed. So let me again get there. Cumulative pregnancy rates means the number of transfers against a pregnancy is the same. So just that in a single embryo transfer, you might have to transfer many times and then might have the same pregnancy rate. But we are in India and we, at least us, we practice in a place where patients, half of them, tell us, yehi aakhri chance hai mera. This is my last, this is my first. That's all I could gather. That is it. And when this happens, if you see the profile of the patient, if the patient is from a humble background, has sold a few things to get IVF done, IVF at a low cost, patient is not as well versed with IVF practices, then I think it's a debate, yes, but double embryo transfer or even sometimes 3 at day 3, not blastocysts, but would make some sense in a place where we practice. This highlights the similar success rates between two groups and raises the questions, why would we inflict greater risk on this patient group when it is not necessary? This group of patients isn't representative of the entire infertile population. Roughly 20% of patients undergoing IVF are over 40, and this increases to around 30% when including those over 38. This group of patients are known to have reduced implantation rates and live birth rates, and they're also on a time-sensitive schedule as their chances of conceiving continues to decline as they age. These patients are an example of just one group where double embryo transfer has to be considered. Again, a place where, a podium like this where a lot of gynecologists and IVF specialists are already here. We talk about PGT, we talk about elective single euploid embryo transfer. We forget again that how many centers do PGT? How many centers can proudly talk about a single euploid blastocyst? How many? I don't think. And that is why being practical is also important. And that is why when a debate topic is given, I'd spend 7 days to actually feel it and get into the role of, I really believe in maybe even do a double embryo transfer and get a good, and then back up this with my experiences. So elderly ladies, yes, in some cases the option for delay between embryo transfers due to patient age or those with age inappropriate ovarian function is not feasible. These particular patients may wish to accelerate family building as long as the patients are fully informed of both maternal and neonatal risks of multiple pregnancy. Is it ethical to deny them this option if a blanket single embryo transfer policy was in place? Particularly in those patients who are about 40 years of age, studies have shown that there is no significant difference in multiple pregnancy rates when comparing SET to double embryo transfer. What about the recurrent implantation failures? Many patients of unexplained infertility fail without any reason. We have no reason. Even when sometimes we all know the endometrium is the main thing. The patient, the first time the patient comes to you and you scan them, at that moment, a good IVF consultant knows yes or no in their mind. And I'm sure when the patient is in the second half of the cycle and on the 17th day and you see a poor endometrium, all you think about is 3 good blastocysts. I don't think that a patient with a poor endometrium, say 7 mm, say 8 mm, with not a good endomyometrial junction, you don't think single embryo transfer. You all the time want 3 blastocysts. You look at her AFC and you go, yes, I have a good chance. But you want 3 good blasts, and that is what about recurrent implantation failures. Can DET be cost effective? Maybe not. See, basically what people think is buy one get one free. एक के पैसे में 2 चाहिए. 18 महीने की मेहनत 9 महीने में करनी है. I understand this. बट 9 नहीं होते वो, यूजुअली 8 में ही हो जाता है उससे कम में. बट there have been conflicting reviews on the cost of multiple pregnancy. One study found that compared with SET, double embryo transfer ranged from costing an additional, Dr. Munjal said dollars, I'd say pounds, 27,000 to 15,000 per extra live birth in women from 32 to 39. It also stated that in those over 39, there was further reduction in cost due to the reduced chance of multiple pregnancies, highlighting that the blanket policy of single embryo transfers might not be the most cost-effective option, particularly for those of advanced middle age. Also, when the government, especially in the last 10 years, has come out with a lot of yojanas. Ayushman Bharat, for example, has caters to a lot of problems of the poor, but it does not include IVF. Also, no insurance company, except for the railways and for some communities, samajis who want to help their own, pay for the IVF cycle. But otherwise there is no insurance company that pays. So a cumulative embryo transfer or maybe successive embryo transfer of a single embryo transfer may also lead to a lot of expenses. And apart from that, the hormones, the tablets, all the rest, all the injections and all the weight, it puts a lot of psychological burden on the patient. The patient might not turn up for a second embryo transfer. I was with Pooja Didi and I used to ask her, why are you freezing them all? Progesterone normal hai, 0.7, 0.6 on the day of HCG. Itne embryos hai aapke paas. You have 17 embryos. Why don't you transfer 1 or 2 blastocysts and try? And why don't you, agar nahi hua to, she used to tell me, a negative result is a negative result. It will, hopes, aspirations, women, you're dealing with women here, hopes and aspirations, they keep dreaming, every time there's this embryo transfer, after that they ask me, sir, 9 mahine, they dream about their schools and their marriages and collecting dowry or whatever, but they start dreaming about that. And when she gets a period or if there is a negative result, that's what Pooja Didi told me, they are shattered. They might not even turn up. Now, if kiska loss hai? That UK patient came to India. Whose loss? So my arguments against the single embryo transfer policy is that the paternalistic approach towards DET subjects pressed to conceive, it means that हम ज्ञान दे रहे हैं patient को. आप दो मत करो, दो नहीं डालेंगे, हम एक ही डालेंगे because I know better. That can be an approach, especially some senior gynecs who might want to follow the books more than, or the studies more than reality. Unethical towards DET eligible subjects in whom successive elective single embryo transfers could delay or preclude conception. Disadvantages as live birth rates could decline. Successive single embryo transfers could increase cost considerably. Elective single embryo transfer are incapable of assuring a risk level lower than that displayed by twin pregnancies. Obviously, it cannot assure. आप नहीं बोल सकते कि इसको placenta previa नहीं होगा. Can you tell that to a single embryo transfer patient? A single pregnancy, you will not get GDM. You will not get. What if she does? She will ask you कि मैंने तो twins मांगा था, एक में निपट जाता, 2 बार किसको BP चाहिए? Nobody wants to undergo preeclampsia twice. I know a famous cardiac surgeon of a local area. He adopted a second child because of the preeclampsia that happened in the first one, and which is a very good thing. But imagine the stress that he must have gone through. So an elective single embryo transfer does not guarantee. Also the psychological burden, like I told you. Let's talk about safety. The majority of data shows more adverse outcomes occur with multiple pregnancies. Adashi et al. Highlighted 2 papers showing no difference between previa, abruption, GDM rates in single versus double. Although there was an increase in neonatal complications, there was no difference in perinatal mortality, Apgar scores less than 7, congenital anomalies or mortality in the first year of life. And the majority of twin complication rates are based on natural conceived twins. However, there has been a study showing that IVF twin pregnancies have reduction of complications by 40% in comparison to those conceived naturally. But should a multiple pregnancy be seen as an adverse outcome? In some cultures, twins are thought to attract joy, happiness, and wealth to a family. This is reflected in the numerous ways with a resounding preference for DET, like Dr. Munjal showed us, with 58.7% of the Danish population going up to 94.4% in the Nigerian couples wishing to conceive twins. Ultimately, I believe single embryo transfer should be performed for the majority of patients, but not enforced as a blanket policy. Medical arguments should be attuned to specific characteristics of the patient, such as age, cause of infertility, embryo quality, opportunity for cryopreservation, and the experience of the clinician and the embryologist also. Embryologists play a major role when it comes to decisions like these. Those with advanced maternal age and recurrent implantation failures are examples of those that will be disadvantaged by a compulsory single embryo transfer policy. So, like how Dr. Munjal began, I would like to end with the same. Clinicians and patients need to work together to discuss the risks of DET and whether it is appropriate for them, ensuring both sides take a responsibility and in a shared decision-making approach. So that means if you are a person, you are a doctor who wants to do single embryo transfer, don't deny that to the patient. Offer that. A cafeteria approach would be better. Offer that to them. And then maybe make them take the decision. And twins में complication हुआ, you can always say, मैंने तो बोला था. If you are a person who wants twins and who wants to transfer more embryos, aggressive, 3, 4, 5, if you want to transfer more, but let them know about the complications and tell them कि I'm transferring more, but if they want single, I will. And fail हुआ तो मैंने तो बोला था. Same thing, again, I had told you. So maybe not blame them, but let us get the patients involved more. Again, these are my references. If you tell the patient single and transfer 2, this might happen. And of course, these are not a result of single embryo transfers. Thank you so much. Thank you, everybody.
Bottle or chalega? Sorry?
Concluding statements.
Okay, so Aditi, you've put me in a very bad position. एक blood से जुड़ा है, एक नाम से जुड़ा है.
That's too good, too good. तो आपको कौन सा पसंद आया?
So पसंद तो दोनों ही है. But the thing is, let's be honest, the world is moving towards single embryo transfers. And if we all had a way that we would have ensured success in all patients with single embryo transfers, we would all be doing that. Also, what we need to realize is that we live in India, where sometimes the cost of IVF is much higher compared to what neonates need in case they're born, say, maybe 34, 36 weeks. So with that in mind, in the current scenario, I don't think twins is such a bad outcome. But what we want to ensure going forward is that we always do a single embryo transfer. And that's going to be the norm. Because once we have PGS or PGTA, as you said, the success rates are highly increased. And in older women, we are going to be having only one probably single embryo to transfer anyways. So that's the outcome. That's what I feel.
So just a small message. There was a recent gazette passed, I think on last week, which says that you cannot now transfer more than 2 embryos. So now it is actually a law in India that you cannot transfer more than 2 embryos. Unless it is you have a very strong medical reason like advanced maternal age, recurrent pregnancy loss, recurrent. So you have to justify, write it down and verify whatever you do. So legally in India, from 1st Jan, you cannot transfer more than 2 embryos. So now you'll have to choose to transfer, go to blastocyst and maybe. From the podium, the message is this.
Yes.
Official message is this. Because these are all young students. They want to
I think this is the first time that in a debate, both the for and against are on the same page. That do the elective single embryo transfer when applicable and when you're confident of the success rates. And when it is, you can't be, we're both against a blanket rule for single embryo transfer. We have a long ways to go before that becomes the norm. So Vaibhav, well done.
I think that's why
the same page.
Indians are very successful. हम हाँ में हाँ मिला ही लेते हैं.
Thank you, everyone.
Thank you, Munjal. Thank you, Vaibhav. Please, Dr. Sujay, please give the mementos to Dr. Munjal Kapadia and Dr. Vaibhav Kapadia. No, the chairpersons have to sit for another session. Vaibhav, please, Vaibhav Nadkarni, please give the memento to Dr. Munjal Kapadia and also to Dr. Vaibhav Kapadia. And do we have Prashant Bhamre sir here by any chance? He was operating. Dr. Prashant Bhamre, are you here? Yes, sir. No, he's not. So I think the second debate we'll have to postpone, Mridula. Sorry for that. So we have Dr. Kishore Nadkarni's lecture coming up next because Dr. Prashant is still in the OT. He's on his way. He'll reach for the next upcoming session. Please clap for the debates. Thank you so much. So now we are having our next session. That is Dr. Kishore Nadkarni will be speaking on sexual dysfunctions in the male and the females.
Good afternoon, friends. I'll have to cover quite a bit of distance, male and female sexual dysfunctions, but I'm only going to highlight the practical aspects and what you encounter in your clinical practice. How does it go for?
Students of Sumandeep Hospital here. Sumandeep Hospital. You all had a poster presentation. Are you all here? Okay. Okay, sir, we can start with your lecture.
So I have been practicing sexual medicine as a part of reproductive medicine along with male infertility and andrology at all our hospitals, and have the opportunity to interact with lot of patients, almost maybe 40 to 50 patients every month in Surat as well as in Vapi, particularly in Vapi and a little bit in Surat. So I'll just go quickly into erectile and ejaculatory dysfunctions and then FSDs, female sexual dysfunctions. Now, erectile dysfunction is defined as the consistent and or recurrent inability of a man to attain or maintain a penile erection sufficient for sexual activity. Usually it is self-reported by the patient or the patient's wife. And it affects a lot of people in the age group of 40 to 70. Even some of the younger patients are affected nowadays because of lifestyle problems, a lot of stress. Younger people are also affected. Diabetes, obesity, metabolic syndromes, hyperlipidemia are all associated. And the one common thing in organic erectile dysfunction is vascular endothelial dysfunction. There is something wrong with the vascular endothelium of the vessels of the corpora cavernosa. Now, basically you have to differentiate between psychogenic and organic. Psychogenic usually occurs in younger patients. The history is very typical. They would say that at certain times they can perform, certain times they can't. They will say, अमावस की रात में नहीं होता है, पूनम में होता है, लाल शर्ट डालेगा तो होता है, नहीं तो वाइफ के साथ नहीं होता है, दूसरी औरत के साथ होता है. You get such strange histories and you know immediately that something is wrong. Now, one example of a psychogenic organic erectile dysfunction which is relevant to a gynecologist is inability to give a sample. When they come to your OPD and they have to give a sample, they will not be able to give that sample because there's a stress, or there may be some other reasons, or maybe there's a borderline dysfunction and in a difficult situation or in a strange circumstance or location, they are not able to give. So I told you this. In organic dysfunctions, it occurs in all circumstances. There is absent or reduced early morning erections. You know that there is something called penile nocturnal tumescence, PNT. And otherwise the sexual development has been normal. Whereas in psychogenic, I already told you, there is some stress factor, some relationship issues, etc. I'll straight away go to management of erectile dysfunction. Now, if you remember, the most important thing, let me tell you first about this inability to give the sample. if you have to give the patient a proper area for giving the semen. So all the recommendations are for having a separate boys' room where they're able to give the sample properly. The room should have a no disturb sign, because just when he's about to give the sample, the sister knocks on the door. Koi hai andar, that will put them off, and for the next 1 hour they'll not be able to give the sample. Sometimes they want their wife beside them. You can give the wife beside them. You can give them a room. Even if there's a nearby hotel, they could come within 15-20 minutes with the container. You can give them some erotic material, could be some video on their own mobile phones. Don't please transmit any MMS pictures to anybody. It's not allowed. And what I do, people who are very stressed out, and especially in IVF ICSI, we usually make it a point to take the sample a few days earlier and freeze the sample, because when you have retrieved the eggs, you don't want not to have the sample and then